स्ट्रीम में आया है कि नहीं देखना है, स्ट्रीमिंग हो रहा है ना, तो इसमें भी देख सकते हैं। ये लूज इसको नहीं हटाना है, ये सब थोड़ा अच्छा ओके you can say about
sir so do you need no need can we get this on that one this one put something
अभी यहाँ पे presented it अभी
no I want to put another thing there yeah lot of time yeah no just keep it yes okay because it's okay because we are using it as a so you need this presentation to this display yes this one you only want to click ഇതുണ്ടല്ലോ ഇത് ഈ ഡിസ്പ്ലേ കാണിക്കണം ഹലോ 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 ആ ഇത് ഇതിൽ കാണിക്കണം ഇത് അവിടെയും കാണിക്കണം ഇത് ഇവിടെ കാണിക്കണം സെയിം സാധനം അവിടെ കാണിക്കണം ഇത് അങ്ങോട്ട് മാറ്റണം ആ വീട്ടിലോട്ട് മാറ്റണം എന്നിട്ട് ലാപ്ടോപ്പ് കൂടെ കൊണ്ടുപോകും അല്ല ഇതിന് സ്പെക്ടർ വെക്കാൻ പറ്റത്തില്ല സ്പെക്ടർ ഇല്ല ആ ലോഗോ എവിടെ കാണിക്കണ്ടേ ആ ലാപ്ടോപ്പ് കൊടുത്ത് വെച്ചിട്ട് എയർ ടൈം കൂടെ കൊടുത്താൽ പറയാം ഇതിട്ട് അവിടുത്തെ എച്ച് ഡി എം എയർ ടൈം കൊടുത്താൽ പറയാം അപ്പോൾ യൂട്യൂബ് സ്ട്രീം ചെയ്യും അതല്ല പറഞ്ഞേ ആ പ്രൊജക്റ്റിൽ പോകുന്ന എച്ച് ഡി എം ഒക്കെ വിളിക്കടാ ഈ ആ ലാപ്ടോപ്പിന് എടുത്തിട്ടേ അത് ഈ ലാപ്ടോപ്പ് ഉണ്ടോ ഇതൊന്നും ചെയ്യണ്ട ഇതിപ്പോൾ ഇവിടെ വരണം അതിനെന്ത് ചെയ്യും അതിപ്പോൾ എച്ച് ഡി എം ഒക്കെ കൊടുത്താൽ പറ്റത്തില്ല ഇത് എങ്ങനെയാണെന്നത് ഈ സാധനം ആ ലാപ്ടോപ്പ് ഡയറക്റ്റ് പോയേക്കും എന്ത് ചെയ്യുക ഇത് എച്ച് ഡി എം കുത്താൻ പോകുന്നുണ്ടോ എച്ച് ഡി എം പറഞ്ഞാൽ കുത്താൻ പറ്റുമോ ഇല്ല സ്പ്ലിറ്റർ വെക്കേണ്ടി വരും സ്പ്ലിറ്റർ കൊണ്ടുവരും അപ്പം അപ്പുറത്തെ ആ ഏതാന്ന് തോന്നുന്നു അതെ നോക്കിയോട്ടെ പൊരിയും കിടക്കും അത് പിടിക്കുക പൊരിയും കിടക്കുക
പാനൽ ഡിസ്കഷന് ഹെൻറിക്ക് ഒരു ഇത് അവിടെ കൊടുക്കണം അവിടെ പ്രൊജക്റ്റ് ചെയ്യാൻ ചിലപ്പോൾ പറഞ്ഞായിരുന്നു അപ്പോൾ പുള്ളിക്കാരനാണ് ഇവിടെ ചെയ്യണം ഹെൻറിയുടെ കാണിക്കട്ടെ
ഇത് ആ പ്രൊജക്റ്റിലോട്ടുള്ള കണക്ഷനാണ് ഇത് നമ്മളെ
ഡോക്ടർ ഹെൻറി ഡോക്ടർ ഹെൻറി when you have panel discussion that has to be connected
ഈ ലോഗോ ആ ലാപ്ടോപ്പ് ഉണ്ടെങ്കിൽ ഇതാണ് സ്പെക്ടർ
Dr. Henry's laptop will be there.
ठीक है ठीक है yes sir 1 minute
इसमें वॉल्यूम ज़्यादा कर सकते हैं क्या? एक शारजा है क्या? शारजा पोर्ट है ना? मेरा लैपटॉप यहाँ पे लगाना पड़ेगा। शारजा होगा मिलेगा ना? कहाँ पे मिलेगा? ये शारजा किसका है?
ये चार्जर इसका है
इसका
वो स्विच और ये भी रखा होगा एक और पोर्ट है इसके नीचे में कनेक्ट कर सकते हैं वो फिर
पावर हाँ देखो जो नहीं है वो खोल लो ना जो यहाँ पे है
ഓക്കെ ആയോ? അപ്പൊ ഇതേതിന്റെ
ഇത് ആ പ്രൊജക്ടർ
ഇവര് ഉപയോഗിക്കാൻ വേണ്ടി പ്രൊജക്ടർ
രണ്ടും ഉപയോഗിക്കുന്നുണ്ട്. ഈ ബാനർ വന്ന് അവിടെ കാണിക്കണം.
ഓക്കെ അല്ല പാനൽ ഡിസ്കഷൻ സമയത്ത് അത്
അത്
മാത്രമേ
മാത്രമേ ഉള്ളൂ.
Assessor.
അത് ഡയറക്റ്റ് കണക്ട് ചെയ്ത് അത് കണക്ട് ചെയ്തു. ഇതിൽ ഇതായി കൊടുക്കേണ്ട ഈ കണക്ഷനാണ്. ആ ഓൺ ചെയ്ത ലാപ്ടോപ്പ് നീ ഇത് കേബിൾ തുഴയാൻ കൊണ്ടുപോയോ? ആ ഓക്കെ ഓക്കെ ഇതോട്ട് കൊടുക്കും. ഈ ലാപ്ടോപ്പില്ലേ ഇത് ഡയറക്റ്റ് ആയി കണക്ട് ചെയ്ത് വെച്ചേക്കുന്നത്. ഇതിന് നടുക്ക് സ്പീക്കർ വെക്കണ്ട. ഈ കേബിൾ വരുന്ന HDMI കണ്ട അത് സ്പീക്കറിന്റെ ഇൻപുട്ടിൽ കൊടുക്കണം. ഒരു HDMI കൂടെ വേണം അതിന്. ആ ഇവിടെ ചെറുതുണ്ട്. അത് ഒരു ഇതിന്റെ ഇൻപുട്ടിൽ കൊടുക്കണം. 10 minutes more. അത് ഇവിടുന്ന് വരുന്നില്ല ചേട്ടാ, ഇനി കൊടുത്തില്ലേ? ഞാൻ ചെറുത് വന്നാൽ അധികം കണക്ട് ചെയ്യണം. ലാപ്ടോപ്പ് കണക്ട് ചെയ്യണം. ഓക്കെ ഇത് അഡ്ജസ്റ്റ് ചെയ്യാനുണ്ടോ? അഡ്ജസ്റ്റ് ചെയ്യണം. എന്തോ അഡ്ജസ്റ്റ് ചെയ്യാം. ഫുള്ളി വേണം. कौन सा लैपटॉप से कनेक्ट उधर से तो उसमें से उसमें आ रहा है लेकिन वो प्रोसेसर किसी मशीन है वो जूम मशीन जैसे एक्टिविटी वो लड़का से पूछना Okay.
Good afternoon, everyone. I would like to welcome each and every one of you here into this Otology Back to Basics program organized by the Department of ENT Nazareth Hospital in collaboration with NIBOY and NIBOY Meghalaya chapter. I welcome all our respective teachers, seniors, colleagues from different institutions and also our dear audiology colleagues and especially our faculties and also Sister Noreen and everyone present here. Now I would like to call upon Dr. Henry Benson Naunu to give the welcome address.
Good afternoon, everyone. It's a pleasure for me to welcome all the eminent faculties from Northeast, and we have Dr. Sriraj, who is from Mysore. A great welcome to you all, sir, and thank you for Dr. Gautam Khan for instilling that courage in me to conduct this workshop. Because I asked him whether this back to basic workshop will work or not. He said, "Why not? You do it." So that's why I went ahead and then planned this workshop and CME on this topic, which would include both the surgeons as well as audiologists to come to one place where we can learn the maximum and we can take home the message and apply it in a clinical applications on a daily basis. So. With that, I would like to call on Sister Noreen, our administrator, to kindly inaugurate the function and to open the second part of sessions. Thank you.
Dear Dr. Gautam, Chief ENT Consultant, Nightingale Hospital in HOD, Department of ENT, Pradisha Hospital, Dr. Sriraj, Assistant Professor, All India Institute, Speech and Hearing, Mysore, Dr. Abhinava Ghosh, Consultant, Guwahati, Ear and Sinus Center, Dr. Niteshu Singh, Cochlear Implant and Skull-Based Surgeon, Shija Hospital, Dr. Donboglang Linser, Additional Professor, Radio Diagnosis, Nigrin's Hospital, Nigrin's, our Organizing Secretary, Dr. Henry, Senior Consultant, ENT Department, Nazareth Hospital, Dr. Sulfi Hasarika, Consultant ENT, Bethany Hospital, all the panelists, members of the Northeastern branch of the Association of Auto Laryngologists, all our delegates and participants. A very good afternoon and warm welcome to all. At the outset, I would like to welcome all our eminent faculty who took out their valuable time and joined us today to be a part of this conference. We are indeed honored to have all of you with us and truly delighted with your presence. Also, all the delegates and participants who have joined us today for this conference. My appreciation to the organizers of this conference, especially Dr. Henry and Dr. Sulfi, for all the arrangements and taking initiative for this productive workshop from CME, along with members of the Northeastern branch of the Association of Otolaryngologists. We have already done with the live surgery session, which I believe is a dynamic educational platform for the participants, through which knowledge is shared by the experts with first-hand visuals of the surgery and the two-way communication with the participants during the live procedures. I'm sure this will be an excellent opportunity to enhance knowledge, review innovative techniques, learn the best guidelines from experts in this field, and communicate, collaborate, interact, and learn the complex surgery skills and updating knowledge from the specialized in this field. Nazareth Hospital always encourage academics, and we have a DNP program in medicine, surgery, pediatrics, obs gynae, and anesthesia. Also, hospital is fully NABH and NABL accredited and value quality care as very important and patients as our topmost priority. I must appreciate the Department of ENT is doing a wonderful work along with our audiologist. Our ENT department started in the year 2003 by Dr. Monica Pyle, and Dr. Henry joined in 2006 as head of the department. The department had progressed from doing basic ENT surgeries to moderately advanced head and neck surgery, endoscopic sinus surgeries, and the most ENT and head and neck surgeries. We have a well-equipped and advanced audiological and vestibular setup. We do most diagnostic endoscopies like fiber-optic laryngoscopy, diagnostic bronchoscopy, and transnasal esophagogastroscopy. The department is in research activities and doing solo study, voice, and also therapies too. I wish you a very productive conference with exciting and encouraging discussions and exchange of knowledge, and I'm happy to inaugurate this conference. May God bless you all with good health to make this event a successful and enjoyable one. Thank you.
Thank you, Sister Noreen. Now we have come to a very special part of this program. We would like to felicitate our faculties and also our special guests. I would now like to call upon Sister Noreen to please do the felicitation. First of all, I would like to call upon Dr. Sriraj Kodanath. Thank you, sir. Next, I would like to call Dr. Gautam Khan, sir, to please receive the felicitation. Thank you, sir. Next, I would like to call Dr. Nitishwar. Thank you. Next, I would like to call Dr. Abhinava Ghosh to please kindly receive the memento. Now I would like to request Dr. Biswajit Gogoi sir to please come forward to receive the memento. Now we have a special invitee who is a senior ENT consultant in Guwahati and also has been very encouraging for each and every one of us throughout the Northeast, all the students and junior doctors and everyone, especially in the field of academics. I would like to request Dr. S.B. Phukan sir to please receive the memento from Sister Gloria. Thank you, sister. Now we'll come straight to the second session, and we'll start this session with the topic anatomy of middle ear. The speaker for this session will be Dr. Nayana Sarma, who is a postgraduate trainee in NIGRIMS. I would like to request her to kindly take your time now. Thank you.
Good afternoon to all the respected delegates present here. I am Dr. Nayana Sharma, second year postgraduate trainee, Department of ENT in NIGRIMS. And I am really grateful to the organizing team for giving me this opportunity. And before I start, I would like to say that I'm a PGT, I'm still learning the basics of ENT. So if I do any mistake, please do forgive me. So what we see in this first slide is the tympanic membrane, and the middle ear is the one which is lying medial to the tympanic membrane. So when we go to the middle ear, so in the middle ear we have 6 walls. The lateral wall, which is the tympanic membrane, the middle wall, that is in the medial wall we have the medial to the middle ear, we have the inner ear. Then we have the superior and the inferior and the anterior and the posterior walls. Now if we see at the relations of the middle ear, we can see that laterally we have the external auditory meatus, medially will be the inner ear, posteriorly the additors to the mastoid, so the mastoid endrum will be there posteriorly. Anteriorly we have the tensor tympani muscle and the eustachian tube. Superiorly we will have the middle cranial fossa, the temporal lobe will be there, and inferiorly the jugular bulb and the carotid artery. Also the middle ear, so when within these 6 walls there is a cavity which is the middle ear cleft, and this middle ear cleft, it is divided into 5 parts. First is the mesotympanum, which is the part medial to the pars tensa. Then we have epitympanum. Epi is like up, so it is the part which is medial to the pars flaccida and the bony attic. Then inferiorly we have the hypotympanum, which is the part inferior to the tympanic annulus. Then we have the protympanum, which is the part anterior to the tympanic annulus, and it is the region of the eustachian tube opening. And posteriorly the retrotympanum, part posterior to the tympanic annulus. If we look into the dimensions of the middle ear cavity, anteroposteriorly and the vertical dimension, it is same, it is 15 millimeter. But when we look at the dimension from the lateral to the medial wall, in the epitympanum it is 6 millimeter, in the mesotympanum it is 2 millimeter, and in the hypotympanum it is 4 millimeter. Now coming to the walls, first we have the lateral wall, also called as the membranous wall. So in this part we have, in the superior part, the bony attic wall. Centrally we have the pars tympanic membrane, the pars flaccida and the pars tensa, and inferiorly is the hypotympanum. So one important thing here is the scutum, which is the inferiormost part of the bony attic wall, and it is the first part, like it is mostly affected by the cholecystoma. So in HRCT of temporal bone, we can see this pointed part is the scutum, which is easily eroded by cholecystoma. Now if we look into this picture, if we are standing in the tympanic cavity and we look at the tympanic membrane, this is what we will see. This is the incus, then the malleus, which will be lateral to the incus, the pars tensa, the pars flaccida. Then in the anterior, in the medial surface of this lateral wall of the tympanic cavity, there are three holes. One is the pectotympanic fissure, anterior canaliculus, and posterior canaliculus. This pectotympanic fissure is also called as the Glycerian fissure. It receives the anterior malleolar ligament and it also transmits the anterior tympanic branch of the maxillary artery to the tympanic cavity. Then this canal of Hooker or the anterior canaliculus, also called as iter chordae anteriorus. Through this, the cauda tympani nerve will enter the medial surface of this fissure and then it runs through the anterior canaliculus, then it goes posteriorly between the fibrous and the mucosal layers of the tympanic membrane. And at times, these two canals, the Glycerian fissure and canal of Hooker, may be confluent also. Then we have this iter chordae posteriorus, which is the posterior canaliculus. The cauda tympani nerve, it enters the posterior canaliculus and it then runs obliquely and downwards and medially through the posterior wall of the tympanic cavity until it reaches the facial nerve. Then we go to the roof. The roof is the tegmen tympani and it separates the middle ear from the middle cranial fossa and it is formed by the petrous and the squamous part of the temporal bone. Now one bony projection from the tegmen tympani is the cog. It separates the epitympanum into a smaller anterior part and a larger posterior part. Looking into the inferior wall or the floor, it separates the tympanic cavity from the jugular bulb, and if it is congenitally dehiscent, the jugular bulb may project into the tympanic cavity and it is separated only by a mucous membrane and a fibrous tissue. So during tympanoplasty, while elevating the tympanomeatal flap, there is a risk of bleeding if the floor is dehiscent. Also, there lies the inferior tympanic canaliculus at the junction of the floor and the medial wall of the cavity, and it transmits the tympanic branch of the glossopharyngeal nerve and the preganglionic parasympathetic fibers. And the posterior part of the floor, there lies the styloid eminence and the roof of the styloid process. Coming to the anterior wall again can be divided into upper one-third, middle one-third, and lower one-third. In the upper one-third is pneumatized and it houses the supratubal recess and the anterior tympanic recess. The middle one-third, we have the tympanic orifice of the eustachian tube, and above that is the canal containing the tensor tympani muscle. And in the lower one-third, it is a plate of bone covering over the carotid artery as it enters the skull, and it is perforated by the keratotympanic nerve and tympanic branches of internal carotid artery. Coming to the medial ear, in the medial wall, we have this promontory. It is due to the basal turn of the cochlea, and over there we can see the glossopharyngeal nerve. There are groups for the glossopharyngeal nerve to run. It is occupying most of the central portion of the medial wall. Then we have on the medial wall the oval window. This is the area of the oval window, which is a kidney-shaped opening, and it connects the tympanic cavity with the vestibule, and it is closed by the footplate of stapes with the annular ligament. If we look at the relations of the oval window, inferiorly we will have the promontory, superiorly we have the facial nerve, then posteriorly comes the ponticulus, and anteriorly will be the processus cochleariformis. This is coming to the round window niche. Is this area? It is triangular in shape, and round window over here is like the round window lies here, and it is obscured by the overhanging parts of the promontory and the mucosal folds. If we look at the relations of the round window niche, antero-superiorly we have the promontory, posterior-superiorly is the subiculum, and inferiorly is the hypotympanum. And this subiculum and hypotympanum, when they meet posteriorly, they lead into the sinus tympani. Coming to the facial nerve canal, so the facial nerve canal is also known as the fallopian canal, and it runs over the promontory. This is the promontory, this is the oval window. It runs over the promontory and oval window in the anterior-superior direction. Coming to the posterior wall, in the upper part there is a large irregular opening, the additus ad antrum, which will lead into the mastoid cavity or the posterior epitympanum. Then we have fossa incudis, which is a small depression below the additus. It houses the short process of incus and its superior ligament. Then we have the pyramid. It is below the fossa incudis and medial to the opening of the chorda tympani nerve. It is a small hollow conical projection and apex points anteriorly, and it houses the stapedius muscle and the tendon. In this diagram, we can see this is the pyramidal eminence. So similarly in the HRCT, we can see this is the pyramidal eminence, and there is a W-shaped structure we can see here, and to the medial of this pyramidal eminence is the sinus tympani, and laterally is the facial recess. Now we will come to this topic of mucosal folds. This mucosal folds was described by a person known as Proctor. He described it as like the peritoneum of the abdominal cavity. So this the mucous membranes of the middle ear, they cover the bony wall and the ossicles in the middle ear. So the head and neck of the malleus are included in the epitympanum. So this is a view from the attic. If we are standing in the attic and we look down, so this will be the view. So in that, the ossicles, we see the head and neck of malleus, the body and short process of incus, and this is the stapes. So if we look into this diagram, there are different ligaments and folds. So if we look at the ligaments, from the head of the malleus, on the anterior direction, this is the anterior malleolar ligament. Then from the neck of the malleus, there is the lateral malleolar ligament, and from the short process of incus, we have the posterior incudal ligament. Now this mucous membranes, they will fold around these ligaments and they will form folds. So in that way, we have this tensor fold. The mucous membrane, they will come and they fold around the superior malleolar fold and they form the tensor fold. Now this tensor fold, it divides the it separates the epitympanum from the anterior mesotympanum. At times this tensor fold can be absent also. If this tensor fold is absent, then there will be again communication between the epitympanum and the mesotympanum, which can be a way for the spread of cholesteatoma. Now this superior malleolar fold, it is coming like if this is the attic, if this hall is the attic and that is the head of the malleus, we can see the superior malleolar fold is coming like this, and similarly this superior incudal fold will be coming towards us into the attic. So this superior malleolar fold, it divides the epitympanum into an anterior compartment and a posterior compartment. And again this posterior compartment by this superior incudal fold is divided into a lateral compartment and a medial compartment. This medial compartment is called as the medial incudal space, and the lateral compartment, however, is not called as lateral incudal, is called the superior incudal space. Then there are two areas, this isthmus tympani ethicus and isthmus tympani posticus. This isthmus tympani ethicus is between the tensor tympani muscle and the stapes, and isthmus tympani posticus is here between the posterior incudal ligament and the short process of incus. So if these spaces are for ventilation of the middle ear, but if these spaces are blocked by some mucus discharge or something, then it can lead to retraction and then cholesteatoma formation can happen. Then there is something known as the Prusak space. In this diagram, this is the Prusak space. Now, this is between the neck of the malleus will be inside, neck of the malleus will be here inside, then outside on the below part there will be the lateral process of the malleus, then externally will be the pars flaccida, and above will be the lateral malleolar fold, and this is the Prusak space, which is a site for development of cholesteatoma. And cholesteatoma from this Prusak space can again spread into the mesotympanum by three ways. One is by the superior inguinal space to the posterior epitympanum, and it is the most common way of spreading. So this is the area of the superior inguinal space. This superior inguinal space is bounded by the medial inguinal fold, posterior malleolar fold, and the interossicular fold. Then if we go to the spaces of the mesotympanum, we have the inferior inguinal space, anterior pouch of Waltrauch, and the posterior pouch of von Frosch. Inferior inguinal space, it is bounded by the lateral inguinal fold, medially by the medial inguinal fold, then laterally by the posterior malleolar fold, and anteriorly by the interossicular fold. Then another is our anterior pouch of von Frosch, is this one. Here lies the anterior pouch of Waltrauch, which is between the anterior malleolar fold and the part which is part of the tympanic membrane, which is anterior to the handle of malleus. Similarly, in the part which is posterior to the handle of malleus will be coming the posterior pouch of Waltrauch. There are also few stapedial folds which are named as obturatorius stapedius between the two crurals of the stapes, then anterior stapedial fold which runs from the promontory to the anterior crura, posterior stapedial fold which runs from the promontory to the posterior crura, plica stapedius from pyramidal eminence to the posterior crura, and superior stapedial fold from long process of incus to the either of the cruras. Then we come again to the cavity. In the mesotympanum, what are the contents? So in mesotympanum, the most prominent part is the cochlear promontory. So and the contents are the handle of malleus, among this the ossicle, handle of malleus, long process of incus, stapes, oval window, round window, and processus cochleariformis. And for the mesotympanum, we can have a complete exposure with the 0-degree endoscope. And the boundaries for the mesotympanum is laterally we will have the tympanic membrane with the bony walls of the epitympanum and the hypotympanum. Medially will be the promontory. Superiorly will be epitympanic diaphragm, which is formed by all the mucosal folds and ligaments that we discussed just now. And inferiorly it is continuous with the hypotympanum. And one clinical importance is transpromontory approach to the internal auditory canal from the promontory. Then going to the protympanum, it denotes the area which is around the eustachian tube, and the boundaries are superiorly the supratubal recess and tensor tympanoid canal, anteriorly eustachian tube, posteriorly is promontory, inferiorly is the carotid canal and a bony ridge called proteniculum. This proteniculum is the inferior boundary of protympanum, and it extends from promontory across the carotid canal to the lateral tympanic wall. And then the structures that we can see in the protympanum are the tensor tympanoid canal, the eustachian tube opening, and subtensor recess. And these can be visualized using an angled endoscope. Now there are, based on the shape of the subtensor recess, we have a type A, B and C. A is a flat type of subtensor recess. Sorry. In A we have a flat tensor canal, in B we have a raised tensor canal, and in C we have a raised tensor canal with a large subtensor space or recess. So we can see here in type A, this is the, if we see in this diagram, this is the tensor muscle carotid artery. So if this is the subtensor space, as we can see in type C, it is going beneath the tensor muscle and it is extending posteriorly. so which can be endoscopically difficult to assess. Then we go to the epitympanum, which is a critical area for cholesteatoma occurrence. The contents of epitympanum are the head of malleus, from which three ligamental folds arise, as we have discussed, anterior, posterior, and lateral malleal folds. It also contains the body and short process of incus, from which we have the posterior incudal ligament and the membranous lateral incudomalleal fold, and this forms the epitympanic diaphragm. Now, epitympanum, as we have discussed before also, this is the cord which separates the epitympanum into anterior epitympanic recess and the posterior epitympanum. So, for the anterior epitympanic space, the boundaries are superiorly the tegmen tympani, anteriorly the root of zygoma, laterally chorda tympani and anterior tympanic rim, medially the bony plate covering the geniculate cannula, and inferiorly the tensor tympani canal, cochleariform process, and tensor fold. In the posterior epitympanic region, it contains the head of the malleus, body and short process of incus, the lateral incudomalleal fold, which segments the lateral posterior epitympanum into superior and inferior epic compartments. Then process space we have already discussed, and it is the most lateral compartment in the posterior epitympanum. Coming to hypotympanum, hypotympanum boundaries is superiorly the funiculus and the tympanic ring. Funiculus can be a complete ring, incomplete bridge, or it may be absent also. And depending on this configuration, the cholesteatoma can extend from the hypotympanum to subtympanic sinus superiorly. And hypotympanic air cell facilitates the extension of cholesteatoma to the petrous apex. Coming to the retrotympanum, it is posterior to the tympanic cavity, and it is composed of myriad ridges and depressions, and it is the most frequent site for cholesteatoma occurrence. Boundaries anterosuperiorly is the tympanic segment of the facial nerve, and the posterior crus of stapes. Anteroinferiorly is the cochlear promontory. Now, in this retrotympanum, we have 3 eminences and 5 ridges. The 3 eminences are pyramidal eminence, caudal eminence, and styloid eminence. This pyramidal eminence, it is situated at the center of the posterior wall immediately behind the oval window, and height is around 2 mm. The caudal eminence, it is situated lateral to the pyramidal eminence and 1 mm medial to the tympanic membrane. Styloid eminence, also known as pollicer eminence, it is a smooth elevation seen in the inferior part of the posterior wall, and it represents the base of the styloid process. Then we have 5 ridges. The caudal ridge of Proctor, it runs transversely from the pyramidal eminence to the caudal eminence. So this is the caudal ridge running from caudal eminence to pyramidal eminence. Then we have pyramidal ridge, which runs from pyramidal eminence to the styloid eminence is the pyramidal ridge. Then from caudal eminence to the styloid eminence is the styloid ridge. Subiculum runs from styloid eminence to the posterior wall of the round window, and ponticulus, it runs from pyramidal eminence to the promontory. So these ridges, they divide the retrotympanum initially into facial recess and tympanic sinus. Then facial recess is further divided by the caudal ridge into facial sinus and lateral tympanic sinus, and the tympanic sinus is divided by the ponticulus into a posterior tympanic sinus and sinus tympani. Now, if we go into the details of the sinus tympani, it lies inferior to the ponticulus, and it is located medial and superior. It is located in the medial and superior retrotympanum. If we look at the boundaries, laterally is the vertical segment of the facial nerve, medially is the vestibule and posterior semicircular canal, anteriorly is the cochlear promontory, superiorly the ponticulus is coming, and inferiorly is the subiculum. Now this subiculum, it is a ridge of bone arising from the styloid complex to the posterior pillar of the round window niche. So this is the subiculum. Now this another thing we have is the ponticulus. This ponticulus can have 3 configurations. In one type, it is completely present, so it is separating the sinus tympani from the posterior sinus. At times, the ponticulus can be absent and the sinus tympani will be confluent with the posterior sinus. At times, the ponticulus can form as a bridge and then the sinus tympani and the posterior sinus will communicate underneath. Now coming to the sinus tympani based on the variations of this ponticulus. So we have total 4 types. One is the classical type, then confluent type, partition and restricted. So as I've already said that when ponticulus is present in normal position, it is separating the sinus tympani from the posterior sinus. If it is absent, then sinus tympani is confluent with the posterior sinus. There can be a formation of bridge in between this ponticulus and subiculum. So this is the sinus tympani which is between the ponticulus and the subiculum. There can be a formation of a bridge in between and then the sinus tympani is divided into 2 parts. And another is the restricted type in which there will be a high jugular wall which will reduce the inferior extent of the sinus tympani. We also have a radiological classification of the sinus tympani in which we have 3 types, type A, B and C. In type A, this is the facial nerve, this is sinus tympani. So in this type A, the anterior edge of the vertical segment of the facial nerve, it is medial and posterior to the sinus tympani. In type B, which is called as deep sinus tympani, the medial limit of the sinus tympani lies medial to the facial nerve and there is no posterior extension. Whereas in type C, it is called a deep sinus tympani with posterior extension, as we can see in this diagram. Then coming to facial recess. Facial recess, we have medially the facial nerve and the pyramidal eminence. Laterally will be the chorda tympani. Superiorly is the incus buttress, which separates the facial recess from adytus and antrum with a short process of incus, and inferiorly is the chordofacial angle, which is 18 to 30 degrees. And this facial recess, it is of adult size at birth and it lies at 2 mm from the level of the round window and 3 mm from the level of the oval window. This caudal ridge divides the facial recess superiorly into facial sinus and inferiorly into lateral tympanic sinus. And the distance between the origin of the chorda tympani and the short process of incus ranges from 5 to 10 mm. This facial recess, it serves as a posterior window to reach the medullary from the mastoid cavity without affecting the tympanic membrane. So it is done by transmastoid digging between the chorda tympani laterally and the facial nerve medially. It is called as transmastoid posterior tympanotomy. And it enables the visualization of oval window, ponticulus and subiculum. Coming to facial sinus, which is a part of the facial recess, the superior part. Boundaries are superiorly inguinal buttress, inferiorly the caudal ridge, and medially the second genu of the facial nerve. And there is no connection of the facial sinus with the air cells of the attic or the mastoid process. Lateral tympanic sinus is the most lateral and narrowest part of the retrotympanum, and it is the space between the 3 eminences: caudal ridge, pyramidal ridge, and the styloid ridge. And it is 1.5 to 2.5 mm in depth, and it has no connection with the attic or antrum. Now, if you give me permission, I'll play one short video of the endoscopic imaging of the
has really taken off, but the study materials have sort of lagged behind. So for trainees to prepare for their surgical case, just with the has really taken off, but the study materials have sort of lagged behind. So for trainees to prepare for their surgical cases is still pretty difficult. So hopefully this video will bridge that gap. This patient is in the surgical position, so they're laying supine, and it's a right ear, so the right ear is...
It's not connected. No. Sound आ रहा है?
up. We're going transcanal, and we'll start pretty easy here, just with the bulge of the temporomandibular joint or the glenoid fossa. Then you'll see
So with this, I come to the end. Thank you.
Thank you, Dr. Naina. Now I'd like to request Dr. Chanaki Sayur to kindly felicitate our speaker.
You have enough charge, right? Charge is there. Good. Yeah. Okay, then let's introduce Peter.
Other laptop?
Oh, yeah.
Laptop.
I think so.
Because
It's not working.
oh, it won't work.
It has. Okay.
That's there. Maybe for the next lecture we'll arrange that.
No, no.
Okay. No, but the charger is not there.
No,
It's there.
Okay, copy. Disconnect this. Yeah.
Thank you. Thank you, Dr. Naina, for that basic anatomy and for taking us to the basics. Next, we'll be having a talk on the basics of auditory physiology and psychoacoustics by Dr. Sriraj Godunath. Dr. Sriraj Godunath is a distinguished professional with an extensive career spanning teaching, research, clinical practice, and administration, accumulating a wealth of experience over 13 years in each domain. He has completed his bachelor's degree in speech and hearing from AWH Calcutta, MSc and PhD audiology degree from All India Institute of Speech and Hearing, Mysore. Dr. Godunath has worked on PhD thesis in the area of assessment of tinnitus. He is an assistant professor at All India Institute of Speech and Hearing, Mysore. His scholarly contributions span publications and presentations in national and international forums, collaborative research with other universities and student guidance of postgraduate and doctoral theses. He had served as a reviewer for various journal articles of repute. He is a member of the Comprehensive Board of Studies in Audiology at the University of Mysore. He is also serving the Indian Speech and Hearing Association Kerala State Branch as office bearer for the last 10 years. He has also contributed to book chapters and obtained research funding from intra and extramural organizations. Dr. Godunath has delivered over 20 lectures. He is known for his valuable insights in the area of tinnitus and hyperacusis, auditory physiology, environmental audiology, and auditory neuropathy spectrum disorders. He is certified in cognitive behavior therapy for tinnitus and tinnitus retraining therapy, affirming his commitment to providing comprehensive, evidence-based clinical care. He also actively engages in public dissemination activities, bridging the gap between scientific knowledge and public awareness. I would now like to give the time to Sir.
Thank you, sir, for the introduction. So, good afternoon, one and all. And just before going to my talk, so this is where I'm coming from. This is the Already Institute of Speech and Hearing, Mysore, which is located in the district of Mysore in Karnataka. And this, we have a beautiful 36-acre campus, and we are Center of Excellence in the Ministry of Health and Family Welfare. It was established in the year 1965. And we have all programs from diploma programs to postdoctoral programs that is happening in the institute. And in the bottom you can see this is Department of Audiology. Some pictures of that. This is Center of Excellence building, and that is again the entrance to the Department of Audiology. So at the outset I would like to thank Henry sir and all the organizers who have invited me for this lecture. Thank you. So I'll just go with the very basics. So what is sound? We all know, like the vibrations that are there, which is what you're going to be hearing. It can be in the form of vibrations. It can be in the form of sound waves that will be, traveling through air, water, or other mediums, and then you are able to hear by certain means. So basically, two aspects here. They are in terms of amplitude or the intensity, or otherwise we say it as what we perceive as loudness, or it can be in terms of the pitch or the quality. What the other parameters include the frequency of the sound. So depending on the greater amplitude of movement, we have increase in the auditory perception. So we can either whisper or we can go into talk into very loud voices. So the auditory system is capable of handling all the dynamic range, basically starting from very soft sounds to a very loud sound as well. And the understanding of the auditory system is in such a way that we are able to include a wide range of frequency, basically spanning from around 20 Hertz to 20,000 Hertz. And we are able to include a wide dynamic range in terms of intensity that is spanning from nearly around 0 decibel to around 120 or even more than that. Okay, so the system is complex in terms of how it analyzes and processes the sound to make us, hear all the kinds of sound that is there in the environment. So now, as I told, we have an audition range of somewhere between 0 to 140 dB or even more. The system, how it handles different frequencies or the intensities are slightly different in terms of the functioning from the external ear to the auditory cortex. So in my lecture, I would like to cover in terms of the contribution of each of these major areas in terms of how it contributes in terms of the frequency and intensity aspects. So we know that the speech frequencies ranges from around 200 Hertz and it goes up to around 6,000 Hertz. And you can see there is a wide range of intensity. There's a wide range of intensity parameters also, which is included along with that. So, this is the most important. So we are able to enjoy this, all these kinds of. This cursor is a little difficult to handle. Sorry for that. Okay, we are able to enjoy a wide range of intensities from 0 to 140 and enjoy this whisper to the plain takeoff sound because of the dynamic range capabilities of the ear, starting right from the external ear to the inner ear. So we know that the human auditory perception is in the range of around 20 Hertz to 20,000 Hertz. And it is why significant for us because we communicate inner frequencies in terms of the speech, as I told, 250 to 4,000 or 6,000 Hertz majorly. But other sounds in the environment that are significant for us is also there between 20 and 20,000 Hertz. So that is the significance in terms of humans, but we can see in the lower animals, the perception varies. For example, if you take elephant, they have a little lower frequency range because they try to communicate even through vibrations. Okay, and so this is why they have a range of somewhere around 10 Hertz onwards and higher. but the higher range is again cut short. Now, if we consider bats, they have a frequency range of around going as high as 1,20,000 hertz. We have around 20,000 hertz. Theirs is much higher. So even dogs, we can say that their ranges go as high as 65,000. So like that, what is significant for that particular species is what matters. We are not bothered just about us, but in terms of understanding the hearing capabilities and everything about other species also. Because, for example, we are not very much in terms of moving our ears. We can't move our pinna. We say that funneling property is there and all that, but we are not capable of moving our external ear. But in lower animals, they have the capability of moving their ears so that they are able to identify pick the danger, what is happening around, so that they can communicate to others. So that is the way, the significance of each species. What is significant is according to their life requirements, what frequencies and intensities they try to, that is what they're trying to be hearing. So now going to the external ear and the psychoacoustics. So when I talk about this particular component, I will say that we hear all these kind of frequencies with the combined effect of the sounds that is starting from the external ear to middle to the inner and going to the cortex as such. So now when I say that, I will say that you are able to enjoy sounds in different locations. For example, you are able to localize the sound. So how is the localization process taking place? The localization process is a complex mechanism which involves the contribution from the external ear, and it goes up to the brainstem in terms of how the auditory signals are identified. So I'll be just talking about all these things in a bit. So now we try to understand that this particular structure helps basically in terms of vertical localization. So the localization we divide into two in terms of how we identify sounds in this horizontal plane and in vertical plane. So when we say that the signal is coming, so how do we pick the signal? So this mainly is contributed in terms of what is the signal frequency that is coming and how the ear is going to be, how these components of the ear is going to be helping in terms of understanding the sound source. So when I say the ear helps, the external ear helps in terms of the frequency enhancements of the frequency range somewhere around 4,000 hertz. That means to say we know that the pits and the ridges are there in the pinna. So these pits and ridges are going to be contributing in terms of the sound reflections. The one is the direct sound source. When the sound is, for example, coming from a right, the sound can directly enter into my canal and then goes into the tympanic membrane. Whereas there can be reflected sounds also, that is because of the pits and ridges what are seen on the pinna surface, on the outer cranial surface of the pinna. So because of this, there is a difference in the sound signal that is happening because there is a reflected sound, there is a direct sound. And when we consider, for example, in terms of the horizontal plane here, now we know that there is a difference in terms of the distance. So this is the closer distance compared to that of this distance. So how we are able to identify is that when there is higher frequency components in the signal, so now consider the sound is in this particular plane. So it is like, slightly towards my right, maybe 2 or 3 degrees or 4 degrees. Are you able to identify that the sound source is coming from this side or is it in the center? So that is because when it is coming slightly towards the right, my right side here will have slightly higher frequency components in the frequency range of around 3 to 5,000 hertz. So your brain tend to perceive, okay, this side is having more higher frequency component. So obviously the signal is slightly placed towards the right. Horizontal plane is much easier because there is always distance factor. Distance factor in terms of your ears are far apart. So when there is a sound that is coming from this side, it is much easier to be identified that it is coming from here, and this side it is here. So there is something called as a cone of confusion also. Cone of confusion is something like this. In this particular plane, we are not very sure whether it is falling towards this side or this side. So that is the cone of confusion. Cone of confusion happens in all different angles. So that is one thing. So pinna mainly plays a role in terms of not funneling, because we say funneling effect is there, but there are a lot of multiple studies which say there is no funneling effect. If you occlude the pinna depressions, there is no change in the amount of intensity that is reaching the tympanic membrane. It is in terms of the perception. You try to find out the threshold of the individual by occluding all the pits and depressions, there is no change in the threshold. But the change is in terms of the frequency of the sound, quality of the sound that is reaching you here, which is perceived by the brain to understand what is the kind of, or basically the elevation, the plane, or the localization component. That is one major thing. So pinna resonance falls around 4,000 hertz. So this helps in terms of perception of these sounds, where basically as I said, in vertical plane localization, you are able to identify sound. For example, we are confused about the airplane flying. So all of us, what we will do, we'll try to look up. Okay, the plane is not found. What we will do, we'll try to move our head. So that's a natural mechanism by which we are trying to adjust our head to find out which side it is coming from. So basically, this side, when there is high frequency component, we tend to perceive, okay, this plane sound is coming from towards my right. So we'll try to locate it by moving our head in that way. It's a natural mechanism by which we turn our head and tilt our head in order to identify the sound source. So that's in terms of vertical localization. So this image also talks about the same thing. One is about the direct sound that is reaching into the ear, and one is about the reflected sound that is going into the ear. And also you can see this right side components. When the sound is given from different azimuths or angles, you can see that the frequency that is enhanced is different. That is reaching the ear. When the sound is given from this plane, you can see there is a there is a peak that is seen towards slightly lower frequency, and there is difference in all these components when there is change in the plane of sound delivery. So what we can understand from here is that the vertical component of localization, the pinna is helping a lot. When there is confusion in terms of where is the sound location, so this particular pinna role is significant. So now, when I talk about horizontal localization is much easier thing. There are two things here. One is the intraoral time difference and intraoral phase difference. Intraoral time difference is when, intraoral time difference or intraoral level difference, and intraoral time difference is otherwise called as intraoral phase difference. That is generally seen for frequencies which are in the low frequency range. And intraoral level difference is when there is an intensity change, that is the higher sounds and lower sounds, how it is perceived. So these two plays a major role in terms of how you perceive the horizontal plane localization. So now, as I said, we have a head in between, so there is something called as a head shadow effect. So when the sound is coming from the right side, on the left side we have a head forming the shadow. So this ear is obviously getting lesser cues compared to that of the right ear. So it's very easy. Okay, we can clearly understand sound is coming from here. Okay, so horizontal localization is much easier compared to that of vertical localization. But however, what plays a major role here is the wavelength. When the wavelength of the signal is much larger, that is there for the lower frequencies, the signal can easily cross over to the other side, but there will be a phase difference of the signal there. So you can easily understand in terms of the phase of the sound, whether the sound is coming from right or towards the left. But in terms of the sound, in terms of the higher intensities or intraoral level difference, intraoral level difference plays a role in terms of the lower higher frequencies. Why? Because when you can see here in this particular image, this is in terms of the higher frequencies that are there. So if there is a obstruction here, what is happening is all these waveforms, the wave that is going to be hitting this is going to create multiple reflections, as I said sometime back, in terms of the pinna causing it. But here you can see it is a one full wave, it is overshooting that and going away. So the low frequencies generally have a tendency to cross your head and go to the other side, but whereas the high frequencies are going to be getting multiply reflected on both the sides. So high frequencies basically helps in terms of, or you're perceiving in terms of the intraoral level differences between the two ears, and low frequencies you're perceiving in terms of intraoral phase differences, because that is going to be crossing, but there is a phase change when the signal is hitting here versus it is going to the other side. So the phase difference helps you in terms of the low frequencies. So there is something also called as the head-related transfer function. So it is not only your ears that helps in terms of the localization, it is also your torso along with your head that is going to be helping in terms of the transfer function. So what is the meaning of head-related transfer function? So when sound is given from different planes, the same frequency sound at same intensity, the amount of intense signal that is reaching the tympanic membrane is going to be different at different elevations. It is not going to be the same. Why? Because when a sound is given, it is going to be, as I told, there is a resonance component of each of the part of the ear. For example, you take the pinna, you take the external auditory meatus, take the tympanic cavity as such. Everything is having a resonant component. So each of these components are going to be boosting the signal in its own frequency components and helping us to perceive the sound directions. Okay. So here, as I said, the body, see when the sound is there, it is striking on me, there is going to be a reflection of the sound from different parts of the body, and it goes into the ear. Also, as I said, there is a direct source that is going into the ear canal also. So the difference in terms of the sound delays, which is happening on towards my right or towards my left, helps in terms of perceiving which direction the sound is coming from. So that is what is the basic simplest example of head-related transfer function. How is the head overall contributing in terms of the energy that is flowing into the external auditory meatus? So here, as I said, the signal is given at 40 degrees above. Here it is given even with the ear, or it is given below the ear. You can see the level of sound that is reaching at the tympanic membrane is different in terms of the frequency components. So here you can see a notch here. Here you can see a peak here towards 12 to 14,000 hertz. And there is slight differences in terms of when the signal is given from the lower part also. So this is how your body is also contributing, not just your ear. Your body is also contributing in terms of the signal going into the ear. So now let us go into the ear canal part. So here we have ear canal transfer function. So basically, we tend to hear all the sounds ranging from 20 to 20,000 hertz. And one classic example, I'd say, we all know about the Boyler's notch or the 4 kilohertz notch that is seen in terms of noise-induced hearing loss. Okay, especially in the early stages, and it becomes broader and more broader over the time. So why is that 4 kilohertz notch? It is basically in terms with the anatomical component. We know the force vector falls in the cochlea in that particular frequency region. There's one most other common reason is that we have a ear canal resonance which is falling around that particular frequency range, somewhere between 3000 to 5000 hertz. So always there is an enhancement of signal by the external auditory meatus in this particular frequency range, which also contributes in terms of why there is more damage at that particular frequency region. So what I'm trying to say here is that, so the ear canal contribution is somewhere you can see between 2000 to around 5 to 6000 hertz. And that means to say the ear canal resonance enhances the frequencies, sound signals, when the signals are in this particular frequency range. So in terms of this particular thing also, we know that the speech frequencies, as I told some time back, 250 to 4000 hertz, that is the overall speech frequency range. And this, this external auditory canal contributes in terms of enhancing the frequencies that are significant for humans to communicate. Basically, the speech frequencies are going to get enhanced. So now in terms of the tympanic membrane vibration for different frequencies. So tympanic membrane, even though we consider it as one single structure, the amount of vibrations it contributes in terms of its quadrants is going to be different. The posterior quadrant and the anterior quadrant, the amount of vibration that it gives inside it in terms of the energy that it contributes inside is different. So the basic most explanation is that in terms of intensity, the posterior quadrant is always more vibrating in nature compared to that of the anterior quadrant. That is the first thing, and this is different in terms of how it contributes at low frequencies versus high frequencies as well. Okay, so here you can see the black part here indicates the depth of movement that is taking place. The more the black in color indicates that there is more deeper movement that is taking place at those frequencies, and you can see how it varies in terms of different frequencies from 385 hertz to around 6000 hertz. So as we can see that amount of vibrations are becoming, the frequencies are becoming more and more. There is different segments that are formed in the tympanic membrane, and tympanic membrane is not just vibrating as a solid disc. It is vibrating in terms of different frequency component, different regions of the tympanic membrane vibrating and contributing in different ways. So this property of the tympanic membrane vibration is called as segmental vibration of the tympanic membrane, and the segmental vibrations keeps on increasing, especially when the frequencies cross beyond 2000 hertz. Up to 2000 hertz, basically it acts as a solid disc, but as the frequencies goes higher and higher, it becomes segmental in nature. And this is the combined effect of tympanic membrane ossicular chain. So here you can see that this is the higher frequency when the vibration is happening, and this is in terms of the lower frequencies when the signal goes inside. So as I told some time back, the entire tympanic membrane is pushed when it's a low frequency, whereas when it's a high frequency, you can see there is difference in terms of the angle of vibrations that is happening as well. And we know it's the double saddle joint that is seen between the malleus and incus, and a ball and socket joint that is seen at the stapes. So here also, when the vibration is taking place in the tympanic membrane is not just pushing the energy directly into the oval window. There is difference in the amount of force that is acting when there is a change in the frequency. I mean to say, When the frequency varies, the kind of movement, it is like piston kind of motion is more when there is a low intensity. But as the intensity increases more and more, there is rotational motion that is taking place at the level of the status. So there is a change in the amount of energy component that is going into the middle ear as and when there is change in the frequency of the signal that is there. So low frequency, it is basically a solid kind of a disk, and as the high frequencies become more and more, the rotational movement of the stapes is becoming more and more. So that is how the middle ear contributes in terms of, the tympanic membrane vibration contributes in terms of giving or coding different frequencies. It is not a solid disk, it gives difference in terms of vibrations as the frequency becomes more and more. So some time back we discussed about the frequencies. Now this is about the intensities. This talks about, again, the black shades indicate more amount of displacement, and the whiter shade indicate less amount of displacement. You can clearly see that this is the posterior part. The posterior part is always, and across all the intensities, the posterior part is more activated compared to the anterior part, the anterior quadrant. So here you can see at 89 dB how the tympanic membrane is acting, and you can see how it is different at 115. So the basic thing what is happening here is, as the intensity is keeping on increasing from the posterior quadrant, the energy transfer is happening more towards the anterior quadrant as well. And also, as I said some time back, you can see the more number of fringes are seen as the intensity increases compared to that of the lower lower intensities. So, and the anterior quadrant is having more amount of vibrations compared to a lower intensity. You can see at 115 there is larger intensity of vibrations taking place in the anterior quadrant. So this also, I mean to say, the tympanic membrane is also coding the responses in terms of intensity and frequency. So middle ear, in terms of sound percentage, the system as we go into the middle ear, so going into the inner ear, we have fluid there, whereas the middle ear component is having air-filled cavity. So here, when the energy goes from the middle ear to the inner ear, there is always lack or the losing of energy that is taking place, because there is a change in the medium from air to water or fluid. So here there is contribution in terms of, generally only 1% of the energy can go from this particular middle ear structure to the inner ear if there is no enhancement of the signal by the middle ear. So basically, middle ear enhances to the loss of the energy that happens due to the change in the medium from middle ear to the inner ear, and it enhances to up about 60% of energy which is lost otherwise. So this is through three mechanisms. One is the lever action of one is through the lever action of the ossicular chain, and aerial ratio. Aerial ratio is the ratio difference between the area of the tympanic membrane and the oval window, and the lever action, and also the buckling. The lever action is basically the size change between the malleus and the stapes, the incus, and here the buckling effect. Buckling effect is the amount of the movement is much restricted at the umbo part compared to that of the upper and lower quadrants. That is in terms of the pars flaccida and the pars tensa. So here, because of the difference in the movement in terms of the energy flow, there is a contribution in terms of the enhancement of the signal, as there is a difference between the different regions. Difference in terms of the the vibratory patterns at different regions, how the signal gets enhanced into the middle ear system. So basically, just to summarize this, the middle ear enhances the energy loss that is that can happen because of the energy flowing from the middle ear to the inner ear by three different mechanisms. So that is the aerial ratio, the curved membrane principle, and the buckling effect. So the loss of energy that is happening, that is the 99% of the loss that is happening, the 60% is gained by the contribution of the middle ear structures. Also, some time back we discussed about the resonance, about different structures. So now middle ear is contributing to a resonance of around 800 to 1500 Hz. I mean to say, when the signal goes into the middle ear naturally enhances the frequencies in the range of 800 to 1500 Hz. And now in terms of the ossicular contribution, so we know there are two muscles in the middle ear system, that is the tensor tympanic muscle and the stapedius muscle. And as I said, we are able to accommodate a large range of intensities in our perception because of the functioning of these two muscles as well. So these muscles, when we talk also, it gets activated. That means to say, it try to reduce the amount of energy that is reaching into the inner ear in order to safeguard the functioning of the cells of the inner ear. So here, these two muscles contract, except for all the transient stimulation, that is the short duration stimulus. If it is more than 50 milliseconds, the middle ear muscle will tend to contract. So we know our speech is a combination of vowels and consonant. So when we have produced a lot of vowels, there is a lot of low frequency energies. So every time we produce speech in terms of louder intensities, moderate and above, there is a contribution of contraction of these muscles, and it is able to, this contribution also helps in terms of increasing the dynamic range. So the middle ear contribution helps in terms of increasing the dynamic range of perception. We are able to enjoy a wide range of frequencies and intensities because all these components are contributing in multiple ways, not only at the level of inner ear. So you can see here in the right diagram, the contribution of outer ear, the middle ear, and acoustic reflex stimulation. You can see in terms of acoustic reflex stimulation, there is a reduction in the energy that is seen at different frequencies, because these two muscles are going to be contracting in terms of the amount of energy that it is going to be giving inside the ear. Even a 10 dB reduction in the signal that is going to the cochlea is going to be a big factor, because loudness, as you know, as it goes higher and higher in terms of intensities, the perception multiplies in terms of 2 times 2 becomes 4, 4 becomes 8, 8 becomes 16, it's like it multiplies like that. So the perception of loudness is a psychoacoustical parameters. It's going to be too difficult for people to bear the loudness. So this particular component is also supported by the middle ear in terms of reducing the energy by the contraction of these two muscles, that is the stapedius and tensor tympanic muscle. So now the eustachian tube, two conditions. One is in terms of petrillus eustachian tube, or otherwise the eustachian tube that fails to open. Okay, one is who don't open, or otherwise it is fully closed. So when we do otoacoustic emissions, we find that if there is a blockage in the eustachian tube, we tend to always get a reduction in the low frequency component. In terms of the low frequencies in the OEs will be absent. That is mainly because the resonance contribution of that particular system is gone. So when that goes off, we tend to get an OE which is lower in amplitude, especially in frequencies up to 1000 Hz. So basically 500 and 1000 Hz gets affected. So this is also, there is some amount of contribution that is there from the eustachian tube. Now the role of cochlea in terms of the auditory perception. So there's something called as tonotopicity. Tonotopicity basically means, it's a Greek word which means, tono means frequency, and topic means, which is in terms of the location. So cochlea is frequency tuned in terms of different parts of the cochlea responding to different frequencies, ranging from 20 to 20,000 Hz. So this sound coding is very important for us to understand all the sounds that is there in the environment. So once a person gets hearing loss, this is something which is seriously affected in terms of understanding the signal component. So now this is the tonotopic arrangement in the cochlea. So we can see here that the basal part of the cochlea codes around 2000 Hz, and the apical part codes around 20 Hz, and all the other frequencies lies in between. So when there is a signal, the traveling wave theory explained by von Bekesi, which has won the only Nobel Prize in hearing at that point of time at 1960, which talks about how the traveling wave is coded in the auditory system, or the stiffness component of the basilar membrane, which is going to be helping in terms of coding the large frequency range. So here you can see that the low frequencies, we'll start from here. There's the high frequencies, which is going to be the traveling wave is originating from the basal part, activating this part and dying off. And mid frequency, you can see it somewhere in the center. And in the low frequency, see that this starts over here, but there is excitation that is happening in the apical part, that is the low frequency part of the cochlea. So this is one major frequency tuning that is taking place. So from now on, we have been seeing all these structures starting from the external ear, contributing in different frequencies. The tympanic membrane, we said how it functions, then the middle ear contribution in terms of the frequencies. And now we are going to see that the cochlea is also tonotopically tuned. And this tonotopic organization is maintained from the external ear till we reach the cortex. It don't end here also. I'll come to that as well. So now, when I talk about critical bands, how this is an assumption basically, it's not a proven thing, but it is considered that there are around 24 25 critical bands in the cochlea. Critical band means once I'm giving a particular frequency of 1000 Hertz, there's a particular region in the cochlea that is going to be responding based on chromatopicity. So that particular critical band is that particular zone where there is more amount of activation in terms of neuronal activation that is taking place when a signal is given. Okay, so this is the beauty of the system in terms of, see now we say that that person is having hearing loss at 1000 Hertz probably. Okay, that does not mean that he will not hear. He will be hearing because the next critical band is going to be taking up. Because that is when we lose the clarity of the signal. We want to hear 1000 Hertz as 1000 Hertz. We don't want to hear it as 2000 Hertz. But when this particular property is lost, basically the hearing shift from that particular frequency component to the next frequency. So that is when somebody's speech also. There will be a basic fundamental frequency, along with it there will be other components as well in my speech. So when I speak, it becomes naturally different for a person with hearing loss compared to a person with a normal hearing. So that is one major component, that the person loses when the person is having a hearing loss, or basically a sensorineural hearing loss. And loudness perception also, we know that the functioning of outer hair cell and inner hair cell. Inner hair cell are different, these two cell functions differently in terms of how it codes the energy. We know the two mechanisms, one is the active mechanism and the passive mechanism. Active mechanism in hearing is when the outer hair cells are going to be activated, followed by that you have the inner hair cells being activated. And the afferent system, the 95% of the fibers, the type 1 fibers start from the afferent system, that is from the inner hair cells. So if you have your outer hair cells lost also, you tend to perceive the jump in the loudness, especially because the passive mechanism is active for higher intensities where the inner hair cells are intact. But whereas for the outer hair cells, for you to hear soft sounds, you need amplification process, which is called as the motor mechanism of the outer hair cells, where the motor functioning is there. When the signal and energies are lesser, the cochlear amplifiers kicks up. That is when you have the hair cells changing its shape. Shape change is possible for the outer hair cell, where it compresses and causes the activation of the the pulling of the basilar membrane. It's a two-way mechanism basically. The basilar membrane moves up, the hair cell gets compressed. When the hair cell gets compressed, it further pulls the basilar membrane up. So this is basically coding the low intensities. So this particular activation is significant or sufficient, or it is required in order to activate the inner hair cells and the inner hair cell synapses, which takes the energy forward to the higher center. So that is the dead regions, we say. When there is a dead region of the inner hair cell, you don't hear anything at that particular frequency, or the entire thing, the edge frequency completely shift to another frequency. Okay, so there the outer hair cells may be completely normal, but the inner hair cells are not able to pick the energy from there, because the conversion of energy into electrical energy or the synapses takes place basically at the level of the afferent system getting activated takes place at the level of inner hair cells. So that is when these components are affected. Also in this graph you can see. So there is a difference in terms of amount of enhancement as the basilar membrane velocity in terms of the input level. So you can see that as the input keeps on increasing, the amount of output that is there that is coming from this particular regions are becoming lesser and lesser. So this is the problem in terms of dynamic range of the individual when the person is suffering a hearing loss. So they will be able to enjoy wide range of sound, but not like the normal person, because the dynamic range keeps keeping on getting compressed and compressed, so that the entire range, for example, these at the higher input levels, they will not be able to include or enjoy the differences in terms of sound. A 2 dB, 5 dB differences they may not be able to perceive. Everything will be perceived as the same loudness. So that is the major problem in terms of individuals who are having sensorineural hearing loss. The dynamic range is compromised. When dynamic range is compromised, they will not be able to enjoy what the legacy, or what we say, the understanding ability as a normal human being is going to be having. And this is because the cochlea is a non-linear structure. It do not take all the intensities in the same way. If we give a low level sound, it is going to enhance it in multiple times, especially because of the motor function also kicking and helping with that. But as we go higher the intensities, it is trying to include the larger range in terms of compressing the sounds. It compresses too much. So this is where the compression in hearing aids also makes a major role. When we give amplification device, we just don't give anything that linearly amplifies the system. We give hearing aids which is going to be compressively amplifying the entire output. When compressively amplifying means as intensities become, for example, So the dynamic range can be as small as 20 or 30 dB also. So how are we going to give the individual, this ability to perceive a wide range of sound? That is the fashion in which the hearing aid compresses the signal at higher inputs. It tries to include that particular differences in terms of 0.5 dB, 1 dB differences, and try to include the entire sounds into human perception. And abnormal loss of loudness I already discussed some time back. So the damage can result in broadly tuned basilar membrane and linear response to the input sound. So when there is a damage, basically the hearing system is becoming broadly tuned. Basilar membrane is always finely tuned. As it will finely tuned, it is able to code a lot of frequencies in the the entire 32 millimeters what is there. It is able to code a large number of frequencies, but it becomes broadly tuned when there is a loss. So that means to say a particular region is having a damage, the neighboring region is going to be taking up. So it is not going to be like the sharpness of the tuning curve. I'll come to that. The sharpness, there is something called the tuning curves that we do. The sharpness of the tuning curves become broader and broader. That means that particular neurons that is there in that particular region is not able to code that frequency effectively. I'll come to that. So this I've already told. I'm thinking it's time. Okay, dynamic range, we know. Amplification devices and nonlinearity. As I said, it is trying to compress the signal when there is a problem in terms of the human auditory system not able to code all the intensities and trying to fix it in the available range of the individual. So this is where the major programming of the hearing aid plays a key role. We just don't randomly program. We consider all these aspects and then only program the individual, the amplification device what is available. So I would not recommend going by the standard programs that are there. It should be finely tuned. It should be finely tuned. Otherwise, they will not be able. They will get more disturbed. Yet, enhancing the unwanted things more and more. So they'll become more and more annoyed. The amount of usage that they'll be doing will be much less. It will become more of an annoyance than helping the individual. So now the auditory nerve is also coding these frequencies in the system. As I told, the fibers that are coming from the type 1 fibers basically that are coming from the inner hair cell synapses, these are also frequency coded. Okay, so that means to say once a particular region of the basilar membrane is getting activated, those particular frequency regions are having their own nerve fibers. So you know that the number of nerve fibers that are connecting one inner hair cells is innervated by 20 to 25 neurons at least. Whereas the outer hair cells, 20 to 25 neurons will spread across and then take information from the outer hair cells. So always the afferent system we have the the first type 1 fibers that are important, that is afferent in nature. So what I'm trying to say is that how the system codes the signal is also important. Here you can see that how the intensity is coded in the auditory nerve. So at different input levels, this is sound pressure level, this is softer sound pressure levels, higher sound pressure level, the auditory nerve activity also keeps varying. So here you can see number of spikes that are generated at an higher intensity is much more compared to a lower intensity. So here also the intensity is also getting coded. As I told, the place is also important. The fibers that are coming from that particular frequency region is only taking the signal, and the intensity is also getting coded in terms of number of spikes the auditory neurons are producing as and when the signal is transferred to the higher center. And the higher auditory system in perception, as I told some time back, the neurons entirely are, the system entirely from both right and left ear, as it goes to the auditory cortex, the entire thing is frequency coded. It is not just seen at the level of the tonotopic organization in the cochlea, it even goes further and even goes to the auditory cortex. There also the different regions are frequency coded. And I'll go to this and explain because it's short of time. So now sometime back I told about localization. So how was this process taking place at the level of brain? So here we have MSO, that is the nucleus that is there in the nucleus that is seen in the SOC. So here we can see that the input from both the ears are coming there, and this is the first point where you have cross connections that are proper from right and the left ear. So here it is connected in such a way that the input is there from that left ear as well as from the right ear. You can see. So it is called as 1, 2, 3, 4 from this side, and ABCD, and 1, 2, 3, 4 in this direction. So what I'm trying to say is that I told some time back the brain tried to perceive which side the sound is coming from in terms of the intensity and the frequency differences between both the sides. So now when the signal is coming from the right side, it is reaching this particular MSO at a particular point of time, whereas there is a delay in the signal that is coming from the left side. So two things, one is in terms of the frequency, how it is coded. Next is in terms of the signal that is reaching the MSO of the contralateral side. So basically, all the localization signals basically are processed at the level of SOC, superior orbital complex. So there, in terms of the time differences that is taking in, it takes into consideration in terms of signal from right side versus left side. So here you can see the neuron D is the last to receive the information from the left ear, but first to get the information from the right ear. So there the coding takes place. Okay, so now this particular neuron is firing faster compared to this side. So the brain tried to perceive, okay, the signal is more louder towards this side, or signal is coming from this side. So this is how the coding of localization takes place at a higher center. And the major source of the coding of localization is at the level of superior orbital complex. And sometime back I told that even in the auditory cortex there is frequency coding. Here you can see the different regions. And you can see that the different regions are coded in terms of this is 2 kilohertz coded, this is 21 hertz coded, and all the other frequencies coming in between. So this, all the structures starting right from the external ear to the brain to the auditory cortex is frequency coded. So when there is a damage to any of these regions starting from the pinna to any of the inner ear structures, there is a change in the entire code that is happening in the human system. So that is what, the hearing becomes more compromised, and the quality with whatever the best device is available, it cannot match with the normal hearing of any individual. So I am taking more time, so I just conclude here. We can have a discussion further also. So this is what I want to tell in terms of this topic. Thank you.
So if suppose now frequency coding is happening like pinna to the auditory cortex, so if you have any frequency loss happening, does any part will any part of the along the pathway will it modify to enhance the frequency, or does any changes happen?
Sir, at the level of cochlea, yes. As I told some time back, the neighboring structures are going to take up. But in terms of all these, external and middle ear components, there is nothing that is possible in that way. Because cochlea, we know that nerve fibers originate from that particular point, and we know that the critical band is changing. So when, for example, there is a damage in a particular component, the next neighboring frequency will take up, because we don't want to lose the information. The whole point of the hearing is that we don't want to lose any information, even though if it is not in sequence or synchrony with the exact information that is coming in, something should be heard. So that happens at a higher level, yes, but not peripherally,
Sir, do you have any data or any research regarding the vibration when it's compared with temporalis fascia and with cartilage? Because many people say it's normal, it's same, the outcome is same. Many people say it's better, one is less. I mean, like physiologically looking, temporalis fascia should have a better vibration pattern than a cartilage. But in Western pathological society, many people are into cartilage tympanoplasty.
Yes, sir.
So there it has to be thick and it doesn't have a partial again vibratory part. So how do you view that?
Sir, that surgical part, I'm really not aware. I'll try, sir, to get in some articles in that particular line.
The one article I've got actually, the tympanic temporalis fascia and the cartilage perichondrium, the cartilage. Now cartilage slicer is given in a different way, but this is the function of the eustachian tube. This is most important. When eustachian tube more functions, with more detection pocket will be there. Therefore, they put the cartilage. But the hearing result based in cartilage after 1 year. If you do a audiogram after 1 year or 9 months, it will be cartilage will be absorbed, this part, and there will be more vibration like the temporalis fascia. Recently I got the article like that. That's really interesting.
Sir,
it is more in listening time.
Yes. Sir, because why I say is, I've read some articles regarding laser hygrometry, something like that, where they measured the vibration of
Laser interferometer.
different
Yes,
quadrants.
different quadrants.
And they say like the posterior quadrant has the highest and the anterior quadrant has the lowest in a normal care, and that is because the anterior quadrant is much thicker as compared to the posterior quadrant.
Yes, sir.
But now, if you compare the thickness of the temporal fascia and the cartilage, it is it's not comparable at all. It's too vast. So in that case, I would personally, thinking with all the perception there, the temporal fascia should have a better vibration power than, because it's a fibrous layer, than a cartilage. But still, I don't know whether it's a biased thing or a thing. But
No, if they do in surgery in cholesterol, particularly the retraction pocket, then you should put the cartilage graft. The concept in the article written like that. And but if there is not much the issue of the retraction pocket, then you can put nicely like what the temple fascia here is just putting. The concept the article is very nice concept about the cartilage. And penicillin cartilage is more harmful. But people are putting cartilage. Why? I was also thinking like that. So thick, the cartilage slicer is coming to give the size of the cartilage. But how high to put the cartilage? Well, low, there is actually more of the absorption of the cartilage there. Therefore, it becomes thin and thin and thin month by month. And after the 1 year, it comes a better way for the hearing. This was the article of meta-analysis.
Dr. Sridhar,
Sir.
we all know that our hearing range, auditory range is huge, from 20 to 20,000. But in all our conventional audiometers, we are only testing from 125 to 8,000. So do we actually have devices to test our whole range?
Sir, we have extended high frequency audiometry also. We can test up to 20,000 hertz, but clinically not used because there is one major research wing that is happening, that is in terms of hidden hearing loss. So there, the conventional audiometry, we go up to 8,000 hertz and we say fine, there is no problem at all. But obviously when we test with extended high frequency, we tend to see a slope. That I'll be talking in my next lecture about it.
Yes,
So yes, yeah.
Because when we talk about tinnitus,
Yes, sir. Yes, sir.
when you have a normal showing audiogram,
Yes.
when a normal audiogram,
We say everything is
you have
normal,
to
yes.
convince the patient
Yes, sir.
that you are having, because you are having a high frequency loss,
Yes.
where it is not showing on the audio.
Yeah.
And the second point is that you are talking about when we lose a certain frequency, the other adjacent fibers will try to
Take over, sir.
take over.
Yes.
But when it takes over, when that other fiber is actually designed for a different frequency. So how does the brain perceive that? Suppose I'm losing an 8,000 and I lost my 8,000 fiber. And you are saying that my 7,900 or
Yes.
7,000 fiber is going to take it up. So how does it identify that sound? It will not be able to identify the same sound.
It won't be able to identify same sounds, but generally this happens over a period of time. So our brain also get plastic to that. I mean, changes happen to that also. So as in the age progresses, we don't feel that there is a change. It's like our hearing, vision, sir.
That is
Yeah.
real plasticity or substitution.
It is substitution that is taking
Substitution
place. Yes, it is substitution that is taking place.
Like your vertigo.
Yes.
In the rehabilitation of vertigo, substitution is there. Correct.
Yes.
And one thing that last, you said annoyance. Yes, many patients putting a hearing aid, they are so much annoyed. They throw the hearing aid like this.
Obviously, sir. Even
But they put a nice spectacle, costly spectacle there. They throw the hearing aid down, but no. And they will bargain. 5,000, 10,000.
you take it back. that keeps happening.
Then
sir.
your inner hair cell, how the outer hair cell comes and inner hair cell, they refine it and goes up to the auditory cortex.
Yes, sir.
That's really interesting.
Yes, sir. And this, sir, like in terms of the hearing aids, it's all about like a proper knowledge about programming of hearing aid. We have acclimatization levels in terms of hearing aid programming. Ideally, when we know that this much amount of loss is there, we initially itself give that much amount of gain that is required for the individual. The individual is not going to be satisfied ever. We have to, we have to progressively increase the gain over a period of time, matching to his requirement. Suddenly, when everything goes loud into his ears, nobody will be comfortable. So acclimatization, we have 3 or 4 levels. So basically, we have to start from level 1, program in 5 to 10 days later, another program after a month. In 2 months, we can complete the program. So it is not one sitting. Every time what happens, we fit the hearing aid, take the money, and they leave it.
So, but the audiologist send the patient away.
Yeah, that should not happen, sir.
They should not do it.
That should not happen.
I told them already forward counseling.
Yes.
And give the patient something.
Yes.
Because expectation is more.
Yes, they have to get acclimated to it. So without that, it is going to be not beneficial. And including my dad, at that point of time, he was not ready to wear the hearing aid. That is also another factor.
Neither are the same thing.
They have a lot of stigma. They have a lot of stigma. Otherwise, also like, why to carry this device? I can handle myself. That's the attitude that is there. So proper counseling should also be associated.
The cataract operation is cochlear implant.
Yes.
Cochlear implant give a different sound, but you put the cataract, you put the lens out, put the intercochlear lens, so nice.
So nice.
I think that point about the frequency getting substituted explains one thing, because many elderly, when you give them a hearing aid, they will come back to you, I'm hearing the unnecessary sounds, this good breathing or the coo cawing, but these sort of sounds were they have been hearing from the childhood. But now because the frequency shift, I think they become sort of intolerant.
That is also yes. The perception is also completely. But with aging, it may not affect myself. For example, 1% loss is hearing today, current sensitive hearing loss. There is no progress. Then we try to improve loss is hearing aids and loss is hearing compared to an elderly. Because they have already, gotten used to that amount of loss. Change in the perception. They won't feel that.
This is उसका पर्सनल है ना वो लिखी जाएगा
The synchronous firing is not taking place. That is what is all the places are like that. We not say we may see it because but the entire corpus is the neurotransmitters that are released, the neuron is not able to see the
How can we stop it? We can stop it.
They tend to hear the signal because sensory and transmission system is the but they tend to hear the signal.
Laptop, that one, no? No, it is live. We are using live. No? We are using live.
They have lot of
Don't ask this. Yes, it's live. Laptop say it. This one only. तुम्हारे पास किसका लेक्चर है? मेरे पास ओके तुम्हारे पास किसका है? सेम वन
She is going up to 1 hour. But करके ये
तुम्हारे पास किसका लेक्चर है?
नहीं we'll get one of laptop from there.
मान ले नहीं माँ
One use for live, one is for using for
No, it's okay. We'll get on laptop.
One last in a similar program of prevention, they put OE on screening. And it is solid outer hair. Then the inner hair cell like always miss.
She has to put the fingerprint. Yes.
मेरा लगा शायद नहीं बैठे
She has to put fingerprint.
But costly and generally
In continuity to my previous comment, suppose I am telling you in a very simplified form, Sare Rama Pada. I am using the high sound, and it is being now shifted to Pada Nisa.
Password. She has to put the fingerprint.
So I am having a
This is not my laptop.
which is already carrying my knee, and I am getting the Sa again in the knee.
Password.
But you have told the outer hair cell can load orthopedic, but more defined to transmit to the inner hair with all these
She
proteins.
told me easily that she's going after 1 hour, not now.
And Nobel Prize going for mathematics.
मुझे तब जाएगा तो 1 घंटा बाद.
मेरा लैपटॉप ले लो.
हाँ?
My laptop.
दे दो.
उसके बाद किसका लेक्चर है? मेरा इसके ओपन नंबर के बाद.
फिर से हाँ. Then we're bringing the laptop, but I thought that.
Yes, she's coming.
Password.
ले लगा कि जो पूरा आर्ट
We have laptop. It's coming.
Okay.
Thank you, Dr. Sriraj, for that very elaborate presentation. Now we'll be having a talk on tympanoplasty, how I do it, by Dr. Abhinav Ghosh.
Oh, it's coming from here.
Everything becomes like.
Taking it here.
Good evening, esteemed colleagues and distinguished organizers. I am truly honored to stand before this gathering of accomplished ENT surgeons. I extend my heartfelt gratitude to the organizers, Henry sir and Zulfikar sir, for this privilege and this opportunity to present this talk. Tympanoplasty, how I do it. So let's start with myringoplasty. What is myringoplasty? It is the placement of an autologous scaffold to allow the growth of indigenous tympanic membrane epithelial cells from the freshened margins to heal the perforation of the tympanic membrane. So now what is tympanoplasty? It is the process to repair the tympanic membrane perforation with or without ossicular reconstruction. And according to some other books, it's a procedure to eradicate disease in the middle ear and reconstruct the hearing mechanism with or without TM grafting. Both are the same thing basically, just the wordings are different. So the goals of tympanoplasty is to eradicate middle ear disease and create an air-containing middle ear space, establish an intact TM, and restore hearing by building a secure connection between the eardrum and cochlea. So, according to the modified Woolstein classification, tympanoplasty is of 5 types. Type 1 is the repair of tympanic membrane without altering the ossicular chain. Type 2 is the repair of the ossicular chain, usually a small IS joint necrosis, along with the tympanic membrane, and just by putting a small strut or bony strut or cartilage in between. Type 3 is of 2 types, is of 3 types, sorry. Just a second. Type 3 minor columella, in which the repair of ossicular chain is done by placing a graft from the stapes capitulum to the tympanic membrane or the menuprium. These two are the diagrams showing the placement of prosthesis between the stapes capitulum and the malleus and the tympanic membrane. In type 2, in the type 3 major columella, we do not have the superstructure. So from the prosthesis placed from the stapes foot plate to the tympanic membrane is type 3 major columella, and type 3 stapes columella is when we place the graft directly over the stapes superstructure and head. Type 4 is when a mobile stapes foot plate remains as it is, we place the graft and we keep it exposed to the sound directly. Type 5 is again of 2 types. There is type 5B is identical to the type 4, except that the stapes foot plate is removed and a plug of soft tissue or fat is put inside. And type 5A is when a fenestration is done in the lateral semicircular canal so as to bypass the ankylosing stapes. What are the materials that we can use?
The materials are fascia. It can be temporalis fascia, fascia lata. However, fascia lata is way too thick for a normal tympanoplasty. Perichondrium, usually from the tracheal cartilage, is taken. Cartilage is also used nowadays for cartilage tympanoplasty, and fat, which is usually used to just plug a small pinhole perforation after freshening the margins. Approach can be postoral, endoral, transcanal, according to the whatever the surgeon is comfortable with, and also depending on the type of perforation, the canal size, etc. Technique: underlay, overlay, interlay, annular resection, all these lays are very good. With all of these give very good results in good hands, so everyone is just free to choose whatever they want. We can just argue about maybe 1 or 2% here and there, but all of them give good results. The next thing is whether do it microscopic or endoscopic. There is a big debate, but there is no debate in my opinion. You can do whatever you want. So microscopic is my choice, along which is, again, I use the endoscope to look at the places which is properly not visualized by microscope, and that's it. Use the two judiciously together and in harmony. Ossiculoplasty is the major part of tympanoplasty as well. So what are the things we can use for ossiculoplasty? Autografts and prosthetic materials are used. Autografts like cartilage, usually from the tracheal cartilage. Sometimes even the conchal cartilage may be used in absence of tracheals, but conchal cartilage is very curved and has peculiar shape, so it's better to use the tracheal cartilage instead. Incus may be used, which usually gives a very good result. Malleus head can be used, and sometimes even cortical bone from the mastoid can be used. Prosthetic materials like Teflon and titanium has gained wide popularity, and glass ionomer, hydroxyapatites, porous plastic, ceramics are also used, but a bit sporadically. Middle ear packing was introduced by Ulstein and Zollner. It provides support to the graft and prevents it from falling, supports the ossicular reconstruction, and gives hemostasis and aeration, but can also cause adhesions, fibrosis, and delayed healing. I never use middle ear packing just for hemostasis or just to support the ossicular chain reconstruction, nothing else, because once you tuck in the graft properly, you don't need anything to support it anymore. How to decide what approach, technique, graft material, packing, etc. has to be done? It all depends on the size of the perforation, location of the perforation, whether any previous surgery has been done or not, the middle ear biology, aeration, very dependent on eustachian tube function, whether there is any bulge in the canal, whether the canal is narrow. The availability of material is also another question, because you need to know whether how much graft is present after a revision surgery, or if any incus or cartilage is present in which you can use for the ossiculoplasty. Finally, it's surgeon's preference. Whatever the surgeon has been trained in and the surgeon is confident with, that the thing should be done so that they can give good results. What are the basic principles of grafting? Grafting, we have to give fresh edges before the graft. Stable graft, we have to avoid medialization, lateralization, and blunting. They have to have a healthy middle ear mucosa. It's very important. And aerated middle ear, the eustachian tube function is good. Handle of malleus I have mentioned here because there is the thing about whether you keep the graft below or above the handle of malleus. Statistically, there is no major difference, but however, I used to always keep the graft under the handle of malleus. So here is the middle ear risk index. We can score the patient according to the symptoms and according to the parameters here, and 0 is, the closer it is to 0, it's better, you will get better results. The closer it is to 12, the higher the chance of failure and complications. Factors influencing outcome of ossiculoplasty are like spite and tracts. Spite, this is surgery. The prosthesis used, infection, tissue health and eustachian tube function will give us an idea of how good the result will come out to be. And TRAX is the basis of ossiculoplasty. So the tension has to be right, the round window protection should be good, the angle of placement of the prosthesis, whether it is centered properly or not, and whether it is creating a space in the middle ear or not. So this is our OT setup. What do we do? First and foremost, we take up the local anesthesia. I just want to mention one thing here. I just wanted to mention of the needle. The needle is a 1.5 inch 25 gauge needle. It is a very thin needle, much thinner than the one which comes with the 2 ml syringe, and it's very good for giving intracanal injections. Here, these are the workhorses of our middle ear work. Most important, sickle knives, side knives, repositors, and wall probes. The scissors, the various forceps, crocodile, cup, and the malleus nipper as well. We get all the retractors, the suctions, all the sizes ranging from 12 to 22. It's very advisable to keep all this in your table while you're working there. The temporalis fascia graft is harvested using these small, very basic instruments. Good burrs and a good drilling system is very paramount in achieving good results in tympano, in which we are exploring the mastoid as well, whether any disease is present or not. And a good microscope is the best thing. I've been working with a slightly inferior microscope. I've been lucky to get 2 good microscopes in 2 good hospitals, and now I think my life has changed. So, preparation of a ear is very important. We need to give a dry ear first. Antibiotics, drops, regular suctioning, steroids, whatever you want to do, we can do to give a good dry ear before surgery. We don't want a weeping or pus-filled ear during surgery. Anesthesia, usually I do all my cases under sedation with 14 Finargan, and I always take an anesthetist with me who, if required, induces more anesthesia with midazolam or even dexmedetomidine, and basically it's under monitored anesthesia. I usually spray a 10% lidocaine spray in the ear canal while the ear anesthetist prepares the patient. I've just seen that it gives a slightly, the patient becomes slightly more receptive to the intracanal injections even while sedated. The local anesthetic injection is prepared by adding 10 ml 2% LOX, 10 ml distilled water, and 10 drops of adrenaline, which will give a concentration of 1:40,000 adrenaline in the solution. This was a solution I learned from Dr. Mahadevia. So this works very well in all the gives good field as well as good anesthesia. Posteriorly, and in the 4 quadrants of the canal, usually 1 ml each quadrant, and the tragus, and if cartilage ossiculoplasty is planned, we inject all these 3 areas properly and well before we start our operation. Post-oral incision, I don't make it up to the bone, we just make it somewhere in between so that we can dissect the soft tissue. A palpa flap is elevated, which is an anteriorly based mucoperiosteal flap, and once we've reached the spine of Henle, we can just incise the canal, and the myototomy will be done, and we can start our middle work. Thinning of the lateral part of the flap is something which we do very commonly. It helps. Why it helps? Because it thins out the flap, and when it thins out the flap, you have more space to work, and since it is just some soft tissue we are removing and nothing else, so it doesn't hamper the results as well. The next step is the freshening of the margins of the perforation. I'm just using a curved pick to make lots of holes around the perforation. Once the holes are made, we just put the pick again into one of the holes and join the two adjacent holes. Once we've done that, we can get a big round strip of tympanic membrane, and now we can have our freshen margins. We can remove this ring with a forceps, and that's it. We are done. Our freshening of the margins is done. We are left with a slightly larger perforation than we had before. So as we can see, the upper three pictures are safe type or CSOM or mucosal type, and the lower parts are the unsafe types of disease. So what we have to do now is we have to decide what kind of flap we want to put, what kind of flap we want to create. What we usually do is we don't expect any kind of disease in the attic. We don't expect to drill the attic or curate the attic in mucosal diseases. So we use usually a anterior based flap. Just give me 1 second. So this is 12 o'clock, this is 3 o'clock, this is 6 o'clock, this is 9 o'clock. So in case of a safe type of disease, what we do is just let's imagine this area to be the meatotomy area. We don't want you to focus on the dotted line. That doesn't matter. I just couldn't find any other picture. So what we do is we make a superior incision, superior to the handle of malleus, about 2 to 3 mm, 2 mm away from the handle of malleus, and we just go straight superiorly up to the meatotomy. That's a superior incision. Inferiorly, we do the same thing, but this time we are about 5 mm or 6 mm away from the 6 o'clock position. What we do is we give a straight incision up to the meatotomy. We have our inferior incision. Now we will have our circumferential anterior incision. This incision will be again all around, but it will be 5 to 6 mm away from the annulus, like this. So, and we will bring it up to the level of the incision, but we will never join it. We don't want it to be a free flap. I'm sorry about the flap drawing, but that's the best I can do. So what this does is we get a good superiorly based flap, and also as we can see here, our vascular strip usually travels from this area. So our vascular strip is also saved in this kind of flap. So just like how I showed in the diagram, this is the superior incision just above the malleus. Our inferior incision now, and then we will just join it with the superior circumferential incision. That's it. These are the incision. Our incisions are done. So next, what do? We go for the flap elevation. We are now here. I am elevating the posterior superior. The posterior tympanomeatal flap. We've gone up to the annulus posteriorly. Here you can see the annulus here. Oh, okay. I can't show my. Now we are dissecting anteriorly and inferiorly. So this flap is good. This is a good place to start, even in cases where the posterior flap is thinned out. Here we can see one. If we just have a look here, we can see that the annulus is visible. Okay, this is just repeating. So we go up to the annulus and that's it. So in our this is not working. No, there is no. You can't pull it. Okay. So this is for the mastoid cases. So this incision is different. Here we've just made a circumferential incision anteriorly, but it is very much laterally. We are almost up to the myotomy place, at the level of myotomy. This was our inferior incision, and this is the superior incision. This is the incision which is coming from around just the anterior inferior part. So what we are doing here is we are making a anterior inferiorly based flap. We don't want a superior based flap because we are expecting this is to be a cholesteatoma or a mastoid case in which we'll have to dig out some epithelium from the posterior superior area, or we might have to dig out some cholesteatoma from the anterior attic, or but so that area we cannot keep a flap. So, and in the anterior inferior area or the inferior area, there is usually no very less cases we get cholesteatoma to be there. So it's a safe place to design a inferiorly based flap. Now you can see here that what I'm doing is I'm just elevating the flap up to the annulus. Here we can see we have come up to the annulus posteriorly, but it's still stuck in the anterior inferior area. So what we will do now is we will go back, and I can't forward the video, so just bear with me. It's very short video. So now we will just elevate the anterior flap again. Yeah. Again, we will go up to the annulus. We can see the annulus. We can separate the annulus slightly from the bony sulcus as well. And once we have done that, we have to create pockets. This is our anterior pocket which we are creating from the anterior inferior area, and we will then, after creating the anterior pocket, we will create a posterior pocket, and we will join these two pockets so that the flap is elevated all around 360 degree. So here we are elevating the anterior inferior pocket. Here we can see that the annulus is also separated from the sulcus. Now we are separating the posterior, we are digging in the posterior pocket. This area is slightly dark, the video, because of my hand, so sorry for that. Yeah. So now we can see that the anterior and posterior pockets are joined. We have elevated the annulus all around, and now we'll just enter into the cavity. This is a mastoid case, so no question of interlay. So what we do here is we go just in the area of the eustachian tube, because even in cases of adhesive otitis media, we can see that there is a small pocket of air near the eustachian tube, and we can always start our dissection from there. So it will give us a better plane, and we will not lose our epithelium here and there. So this will be the interlay technique of doing our mastoid part is gone. We will not talk about mastoid anymore. This was just for the flaps. So now we are going for the type 1 tympanoplasty here. So what do we see here? We can see that the annulus is exposed, and now what we will do is we'll take a right angle pick and just slowly engage the annulus in such a way that it separates from the underlying mucous membrane. Yes, we can see that the underlying mucosal layer has been separated completely anteriorly, and now we are going to separate it posteriorly. Now the problem with separating the annulus from the mucosa posteriorly is that we need to enter into the we need to denude the malleus as well. So we have to cut through the mucosa even if it is a small perforation. So in interlay we get a good mucosal bed all around except in the posterior superior area where we don't get much support. But we are not worried about support because in the posterior area, because that is the area where the graft is most well placed. Next we go in for the denuding of the handle of malleus. This is looks a bit simple, but it's not always. So what we do is we use a very sharp knife. We always have to use a very sharp knife, make an incision into the periosteum and just pull. Just slowly pull, and this whole thing will separate. I use a pick to separate the anterior aspect of the malleus as well. And here in this edge of the handle of malleus, it's always stuck. So it's very difficult to remove this part. So what we can do here is we can do this. we just use a forceps to slowly dissect it out. It might look that I'm using force, but I'm not using any force at all. So this is dissected, or what we can do is we can nip the handle of malleus as well, especially in cases where the handle has been very much medialized. So we have gone inside the middle ear, and now we are having a look inside the ossicles to see there is a IS joint necrosis. What can we do here? We can place a piece of cartilage between the joints and wrap a thin piece of fascia all around the joint. And in such cases, we can use glass ionomer and bone cement also to bridge the gap. I have not used glass ionomer and bone cement, but I am very eager to do so. I think so. I hope I can use it later on. So what do you do in this kind of case? The IS joint is gone, and a good part of the long process of incus is gone as well. So what can we do in this kind of case? We have a good enough incus, so we can try incus interpositioning ossicoplasty. What we do here is that we are just drilling off this long process of incus. We don't require this. This is a good process because this is a good technique for the ossiculoplasty, because the incus is available locally, and it's in the developing countries and the underdeveloped countries is one of the most popular materials for ossiculoplasty, other than cartilage as well. So what we're doing here is we will so this is the area where we had cut off the long process of incus, and now we are making a hole inside. This hole will house the head of the stapes, but as you can see, I'm just slightly elongating the hole as well. That's because that sometimes what happens is we need to house the upper parts of the suprastructure as well. So if we have an elongated hole like this, then it sits pretty well. So next what we do is we in the short process of incus, we can between the short process and body we can make a groove. This is the groove where the under surface of the malleus will rest. So our prosthesis will be between the stapes suprastructure and the under surface of the malleus. Here you can see we are making the groove. Yeah, we can see the head of the stapes, we can see the malleus. Just put it in. It looks pretty simple. Yeah, just put it in, just slide it over under the malleus, and that's it. That's done. We have a very stable assembly, and what we can just appreciate the round window reflex as well. I can't. Okay. So, what do you do in cases where there is no incus? We can go for normal cartilage, tracheal cartilage placed over the stapes head. This is one of the simplest ways to do a ossiculoplasty, and it gives very good results as well. So what we do is we are creating a bony groove. We are creating a groove just above the bony sulcus. So we'll place one end of the cartilage inside the groove so that it's stuck, and another end will go just above the head of the stapes. We'll just place it there. What we can additionally do is we can make a hole in the in the cartilage in such a way that the stapes head fits in, and that's also a very good type of ossiculoplasty. This is a very stable, and I've gotten very good results, good hearing results with this one. So no malleus, no incus, only stapes suprastructure. What to do now? We have tried this. What is this? This is the septal spur cartilage which we have used as a cap over the suprastructure. As you can notice that I am showing with my sickle as well. There is a good round window reflex, and you can see there is this groove for the stapedius tendon as well. We have to make it in such a way that there is a groove for stapedius tendon, and this whole cartilage fits very snugly. This is a technique shown by Dr. Vijendra, and I have used in one of my case. It was a revision case, but I don't know, maybe there was some mistake, but it was not extremely satisfactory, the post-op audiometry. So only foot plate, what do we do? We can use a tracheal cartilage shaped in such a way that it becomes an L. We have perichondrium on one side and we don't have perichondrium on the other side. So we cut the side without perichondrium and we place it in such a way that it's shaped like an L. The smaller part of the L will rest over the foot plate and the longer part of the L will rest in the groove which we had made before for the straight cartilage. So this also gives very good results as well. But in some cases what happens is the graft pulls the cartilage away from the foot plate, and in those cases it can cause a bit of hearing loss post-operatively. We can, in that case where we have only stapes, we can use this technique as well. What we have done here is there is a good healthy incus which we had we could salvage, and since we didn't want to use anything else that time, and I just suffered a cartilage displacement recently. So what I did was I just put the incus. It fit very beautifully, just fit very snugly like a glove. Just look at the stapes foot plate and just look at how will the incus fit. It fits very well. Now I'll just show you the reflex as well. Can you see the reflex? Yes. The reflex is very nicely, it's shown very nicely as well. Now we just put a cartilage over it. We just place the cartilage over it. There is nothing, we can't fix it there. So we just place a cartilage over it and then we just complete the grafting. Since it fit very snugly, I didn't think there was any more requirement for gel foam or anything else to support it. So we just finish our tympanoplasty with that, using the body of incus. Then we have recently started using Teflon tops. Similar, we use it in cases where there is only foot plate. We place the top, and this was a case in which there was grade 3 retraction and there was extremely thin TM. So what we did was we thought we'll keep a shield graft as well, shield cartilage graft as well. So we were going to place a cartilage anyways over the top, but this one was a big one, so that we gave some support to the tympanic membrane as well along with the top. Here we can see, just don't look at the the vibration is above the reflection. This is the endoscopic view. Since it is coming from the side, it looks very it's like oblique, but it's we can see that the graft is in its proper place and the cartilage also. So we used a big cartilage for that. So titanium as well is the same thing basically. We just need to cut it properly. We just need to cut it according to the size. The size has to be the main problem with the size of the tops is it has to be slightly lower than the annulus, because we will be placing a cartilage over it, and if it goes above the annulus and then you place a cartilage again over it, then it stands out too much. So we need to cut it in such a way it's slightly lesser in height than the annulus, and then we place a cartilage over it, then place a graft, and that's it. This one, I don't know how, but this one had very good, maybe because of the footing over the foot plate. It's the reflex also is very nice. Whenever you can see it, I think so. We will see it here. I think so. We have already seen. Yeah, this is where I'm touching through the TM. The reflex is very good. So the ossiculoplasty is done. Just before ending anything, we have to explore the mastoid. Actually, at least I have to explore the mastoid, because this is how I do it. I don't feel confident without exploring the mastoid and just seeing whether patency is there or not. Very simple. Just whenever we get patency, just that's it. That's the end of the drilling. So we just drill and suck with a 12 suction, and once this cotton ball rise up, we know there is patency. That's it. We are done. Harvesting the temporalis fascia, I don't think so. We need to see a video for this. And this is the grafting. So before grafting, what we do is we reposit the tympanomeatal flap back again, and then we see whether it has turned around on itself or not, because many a times we find that the flap has turned around upon itself, and that is a very big and messy thing to do with the graft inside. So we resolve all that beforehand itself. Before pushing the graft, we push it directly under the handle of malleus and towards the anterior sulcus as far as possible, and reposit the posterior flap back again. Yeah. Now we'll just go anteriorly and search for the graft, because we won't be finding it anywhere near the sulcus. So we search for the graft, pull it out with a suction, and then place it in such a way that it plasters over the anterior canal wall. And then we'll take the annulus and push it in over the graft into the bony sulcus. Now once we've done that, what we can do is we get a basic, this is our primary part of the grafting done. So this is just the first part. Now what we'll do is we'll go back again and we'll make the graft and the flap into a single unit. Once we've done that, since it's a wet graft, the graft almost sticks like glue with the temporal with the tympanomeatal flap. Just see this, we are just making it into one single layer. Yeah, and once it is made into a one single whole big flap, then it's very difficult to remove it. It's even if you put suction directly, we have to use a smaller suction. We can't use a bigger one, but still it's very difficult to for the graft to fall. And all around tucking, the most important part is anteriorly. We have to check anteriorly again and again. We have to make the graft and the tympanomeatal flap in such a way that it becomes a single unit, and that single unit can be manipulated again and again, so that we can check and we can have peace of mind once we have done the operation that this, until and unless there is a bad infection, this ear is going to be good. There is not going to be a residual perforation. All around, make it into a single thing, single flap, and that's it, we are done. Now what we'll do is we'll take a large 12 suction and we'll put it in the mastoid. Now we can see the TM is jumping like a trampoline. Same thing we do here, just to show. I do this in all my cases. Even if there is a small gap, there has not been there is no tucking in one area. That area will fall as soon as we put the 12 suction, because it's quite a powerful suction. And then we just pack. I don't use Merosil, but this was a diagram I got. So I just pack with gel foam and put a cotton or whatever, or a gauze piece packed with ointment, and that's it. Our thing is done. So thank you.
Check the stationary function before doing the operation.
Sir, we do.
How do you check?
We can use tympanometry to do that.
That's supposed to be done correctly.
No. Tympanometry will show us whether there is any defect or not.
That you see by your right C type. That's a defined.
No, if there is a perforation, there will be type.
I asked a question to Mohan Commission this time in Dibrugarh. No, you have a clinical term.
Regarding the vascular stream, Robert Vincent actually does not believe in the vascular stream. He takes out the whole.
Yes, sir. Full cup.
I have tried taking out. You get confused.
Yes. No, even if in some cases when there is by mistake also you put a drill and that whole thing comes out, but the healing is the same. Doesn't matter. Yes, putting it back.
Beautifully demonstrated.
Very nice. Now I want to ask you, your KNL drop of adrenaline, it is still water. That does not make 1 inch, but it will make 1 inch when it out. Because 1 ampule of adrenaline. How do you tell me? I depend on what you do. If the 1 ml is 80 go for it. No, not go for it.
Finish it off. What go? It's too long. Can't do it. It'll be long. Too long. Too tiring. For me, it's okay. For you, it's okay. It's okay. It's okay. Talk
That at least it'll shorten the time. You do both. Yes. For you also it'll be easier. For them also asking questions. It's very important. I'm also waiting to listen.
Yeah, premix. Already 3 feedback. In that case, we put in the inner wall with the one and the outer one we get the normal what is it like? It's not using 2% level. He's using 2% level can be this level with him you know get it plain no we get we get it yeah we get it log yes the log we get 2% only any husband they keep 2% only but we need the one in 2 lakhs.
Okay. Now we'll go to the next session. Thank you, Dr. Abhinava Ghosh. Dr. Abhinava Ghosh he did his MS ENT from Silchar Medical College and fellowship from Jain ENT Hospital, and he's currently consultant at the ENT at Guwahati Ear and Sinus Center in Chikitsa Clinic at Guwahati. Now we'll have the next session from Dr. Sriraj. He'll be speaking on both the topics. One is in overview and audiological assessment of tinnitus, and also the audiological management of tinnitus.
Thank you. So we'll straight away go to the content. So this is a famous quote by Beethoven. Only my ears whistle and buzz continuously day and night. I can say I'm living a wretched life. So tinnitus is something which can really affect the quality of life of an individual. And there are lots of ways people manage it. Like you go search Google for options for treatment for tinnitus. Lots of things. You go to Amazon, there are tablets for it. You can buy on yourself and have it also. But I don't know how far all these things are going to be beneficial. So tinnitus is basically perception of sound in the ear or head in the absence of external sound. So that is the classic definition of tinnitus. So we don't hear anything like a sound from the periphery, but in your auditory system there is something that is constantly ringing. Okay, so tinnitus with associated suffering is just called as tinnitus. But tinnitus without associated suffering is just tinnitus. But it is called as a disorder when the person's life is significantly affected. So tinnitus is conscious awareness of a tonal or a composite noise for which there is no identifiable acoustic source. So there is no external sound, but in the auditory system you are hearing certain things. So it is a tinnitus disorder when they're associated with emotional distress, cognitive dysfunction, and or autonomic arousal, leading to behavioral changes and functional disability. So tinnitus, as said, there is no external stimulation, there is contribution from the higher centers, and these things will become complex and start affecting individuals' life. That is when tinnitus becomes a disorder. So many individuals, including like all of us, would have heard some form of ringing in the ear at some time. But that is not called as a disorder because that is not affecting your life as such. It is just a phantom perception. For some period of time, it vanishes. You forget about it. But when it continues, it becomes more and more complex. So two types generally. One is central and one is subjective and one is objective. So subjective tinnitus is defined as an auditory perception arriving without an internal or acoustic stimulation. So this is the most common type what is seen, and the sound is perceived only by the patient. It is not recordable. and origin is considered to be auditory system. I'll tell you sometime later, like, what can be the source of the origin. And physiological mechanism is not clearly known. It can be because of chemical imbalance, hyperactive air cells, or the nerve. So next is objective tinnitus. It is associated with an identifiable organic cause that can cause other than sensorineural hearing loss. It can originate from the para-auditory structures. It can be strictly audible to clinician or any other observer. There is one classic thing we say: the objective tinnitus is heard by the person who is examining. It can be, most of the time, it is pulsatile in nature, and the turbulence of the blood flow or the muscle contractions are more often perceived as tinnitus in objective. So this talks about the prevalence data of tinnitus. This is from a systematic review done in 2016, which they have collected information from all around the globe, and this is the prevalence of tinnitus. You can see it's a very prevalent condition. You can see we're ranging 5, 24, 14, 22.4, 30%, 15 to 16, 9 to 27%, 20.7%, 9.7 to 20.7%. It's like this, you can see it's a wide range of prevalence that is being reported in tinnitus. So basically, most of the studies say there is at least 10% of the population is having tinnitus. It may not be a tinnitus disorder as such, but it is some form of tinnitus which is bothersome. So now in Indian context, we have first few studies which says that the prevalence of tinnitus is 16.81%, and 60.9 of these individuals were males, and 97.5 of the individuals with tinnitus had hearing loss also, and 28.53 of individuals with tinnitus had moderate degree of hearing loss. And another study, 29.3% of the study subjects showed increased prevalence in greater than 40 years of age. So the trend generally what is seen is around 15-20% of the population in India is having tinnitus, and this prevalence become more as the age progresses. Now again, in a few more studies, in children and adults in normal hearing, there is a prevalence of 4 to 46%. In children it is very prevalent actually, though they don't know to report properly if asked questions about the form of tinnitus that they hear and all. It is very prevalent. In children with hearing loss, 23.5 to 62. In adults, in tinnitus, 5.1 to 42.7. Bothersome tinnitus, 3%, 30%. So all these studies, like across age, it is seen that tinnitus is a very prevalent condition. And one of the most significant findings is that 70 to 80% of the tinnitus patients have significant hearing loss also. So now causes, subjective and objective. Otological disorders, nasopharyngeal diseases, dental pathologies, pharmacological factors, allergy, metabolic dysfunction, neurological disease, anything that you label is a cause for tinnitus. So now causes for objective tinnitus: tracheal eustachian tube, cardiac or vascularities, conductive hearing loss, atherosclerosis, mass behind the tympanic membrane, vascular tumors in the middle ear muscular contraction, Page's disease, and genetic. Genetic don't come into the objective tinnitus cause, but in general I put it here. Because often there are studies that are coming up stating that there are specific genes identified which can cause tinnitus. So sometimes there have been studies in vestibular system, and there are certain genes that code stress also. So these genes are much prominently seen in individuals with tinnitus. There are certain studies that are happening in this particular line as well. And now going into the pathophysiology. So the thing is that tinnitus can be an origin from anywhere in the auditory system. So we'll go in detail about it. So one is that it can happen at the level of inner hair cells and its afferents, at the level of outer hair cells and their efferents, the discordant dysfunction theory, and limbic autonomic nervous system. Let me talk about it. So now talking about the level of inner hair cells and their efferents. So some time back we discussed about type 1 fibers that are arising from the afferent system, that is basically coding from the inner hair cells. So here, what happens is there is a synaptic connection alterations that is happening between the inner hair cells and the cochlear nerve that could boost the spontaneous activity for the neural fibers generating tinnitus. So till now, most of the studies, most of the literature talks in terms of tinnitus having a peripheral origin with respect to starting from the cochlea. Cochlea is a peripheral structure. It's starting from the cochlea, and that is the origin of the tinnitus, and then it gets enhanced as it gets carried forward in the auditory system. through all the auditory nerves and then going to the higher cortical structures. So this particular theory talks that there is problem of ionic channel function or regulation, and that may be a major underlying cause for tinnitus. So that is because the inner hair cell synapses are non-functional, or there are abnormalities in the function of inner hair cell synapses. So now talking about outer hair cells and their efferent. So outer hair cells, we know it is innervated by the type Q neurons, and there is no spontaneous activity that is happening in the type Q neurons, or no action potential that is happening from specifically from type 2 neurons that are coming from the outer hair cells. And understand that there are certain output that is coming from the type 1 fibers that is coming from the efferent system. So there is a mismatch in the system where no output is coming from type 2, some output is coming from type 1 fiber. So this mismatch, which leads to an imbalance of type 1 and type 2 fibers, could be a possible source of generation of tinnitus. So this says OHC is a site of generation of tinnitus. And there's something called as a discordant dysfunction, which combines both, which says that there is damaged OHC plus intact inner hair cells, and there is a decrease of signal through type 2 fibers because there is a damage in the outer hair cells, and which causes a disinhibition in the dorsal cochlear nucleus. And most of the literature, when we search, dorsal cochlear nucleus is considered as one of the key structure where it codes to the origin of tinnitus. Okay, so disinhibition of the disinhibition in the cochlear dorsal cochlear nucleus, and there is a increase in the neural activity. So basically, this tries to say there is an output that is reduced from the outer hair cells, and the dorsal cochlear nucleus tries to enhance this activity or boost the activity to compensate the loss by the what is coming from the outer hair cells, and this is considered to be the tinnitus related activity. So, but tinnitus, don't become tinnitus or become problematic at that point of time. It becomes problematic as it goes to the higher center. So that is explained by the neurophysiological model by Jastrepov in 1990. It's one of the classical theories which talks about tinnitus. So here they say the site of origin is always a periphery, that is basically the cochlea or the auditory nerve, and the detection happens at the level of subcortical structures, and the peripheral and the perception and evaluation happens at the level of cortical structures. So here they also say that there are some other structures like the limbic system and the autonomic nervous system which are interconnected, and if all these put together, you will have a tinnitus disorder. It is not that in its origin is somewhere in the central system. This also talks that the origin is in the peripheral center structure only, either at the level of inner hair cell or the outer hair cell. But it becomes a problem when the autonomic and the limbic system gets involved. So there is when people try to react. So now I say there is a snake in the room. So what is going to happen? Some people are not bothered, but some people maybe they're really scared. So what they'll do? They'll try to move out of the hall as fast as possible. So now when I say the tinnitus is there in you, or like it is there, it is not, bothering you at the moment, you're fine with it. But suddenly the time, you start reacting to it, there is a snake. Till now you didn't know there is a snake. You were not bothered at all. There was no such of an autonomic system activation happening there. So now suddenly there is an autonomic system activation, you try to fight or flight, right, basically. So that causes, that is otherwise called as reaction in the neurophysiological model. And when reaction takes place, it becomes more and more stronger in you. Until you start reacting to something, that particular thing becomes more and more stronger in you. That is when tinnitus start to become bothersome. So this is a very classical theory which talks about the involvement of the peripheral structures and also how it gets stronger as in when the limbic system gets involved. So this is what I have explained. So there is a periphery, the sound source, and it is the subconscious. There is detection process that is happening. It goes to the cortical and other cortical areas. There is an interconnection with the limbic system, and when the limbic system, which codes the emotions, it gets involved with. Then there are reactions. When it happens, it becomes more and more stronger. It becomes more difficult for the tinnitus to be taken off from the individual. So till now, the management options, audiological management options, there is no option which can cure tinnitus. So it is training them how to live with tinnitus to avoid these reactions. That is the entire model behind the tinnitus retraining therapy. So tinnitus retraining therapy, we don't take off the tinnitus. We make the individual habituate to the tinnitus that is there. I'll come to that when I talk about management. So now a little more of pathophysiology. So the site of generation of tinnitus, It is cochlear in origin. It is strongly associated with the frequency of psychoacoustic identified tinnitus and the audiometric profile. So most of the time what we see clinically is that when we try to do a psychophysical assessment of tinnitus, when there is maximum loss, tinnitus frequency is generally corresponded to the maximum loss in the audiogram. So for example, there is a notch at 4000 Hertz. Most likely tinnitus is centered around that particular frequency. It's not always true, but most of the times it is like that. And so it is, the first says that it is cochlear origin, but it's contradicted because surgical section of the auditory nerve does not eliminate tinnitus in every case, which favors that rather a central or rather than a peripheral origin in tinnitus. So even if there is a dissection done of the the auditory nerve, even still the tinnitus persists. So that means that tinnitus is still a higher center activity, not at a peripheral level. So there can be complex interaction between peripheral and central mechanism within the auditory pathway, and this is considered to be the most known. As I told some time back also, even the the neurophysiological model talks about tinnitus origin as peripheral, but it gets enhanced or become a disorder when it gets collectively added with the cortical roles. Cortical in the sense limbic and autonomic nervous system. Usually there are two or more triggers. That is, example, it can be noise exposure or hearing loss, emotional distress and somatic factors, and are necessary to elicit noticeable tinnitus. So tinnitus is noticeable, it becomes a disorder when there is more contributing factors. It is just not a bothersome sound like everybody has. It is not at all a problem, but it becomes a problem when it is associated with higher centers. So the cochlear tinnitus generated by aberrant activity in the inner ear, which is prolonged to the cochlear nerve and central auditory pathway. And it's a peripheral tinnitus or peripheral dependent tinnitus, that is tinnitus associated with cochlear spontaneous activity. And peripheral independent tinnitus, central tinnitus, the tinnitus that that is independent from the cochlear spontaneous activity. So there are different studies which says what is the origin of tinnitus. So it can be tinnitus purely cochlear, it can be cochlear dependent, or it can be purely central also. So lots of theories which talks about different origins of tinnitus. Now in terms of the cellular mechanism, so generally there is loss of OHC electromotility, and there is loss of synapses between inner hair cells and the peripheral spiral ganglion neurons, that is synaptopathy. There is damage to the cochlear bundle and death of the outer hair cells or inner hair cells, or the rupture of the tympanic membrane. So these are the probable causes of tinnitus generation at a cellular level, at the cochlear level. It could be due to loss of electromotility. In the first lecture I told about the electromotility property by which the outer hair cells are able to shape change. When they become depolarized, or they send the neuronal or release the neurotransmitters, the cell is going to get compressed and bulkier, and as it becomes hyperpolarized, the cells are going to become elongated. And so if there is a problem in the electromotility, that could be the possible reason of generation, or it can be loss of synapses between inner hair cells. I told some time back about this, and this is generally called as cochlear synaptopathy. So that is a term that is coined in the year 2009 after I just forgot the name. I'll just come back to her name. So that started in idea in 2009, and it became stronger and stronger over the time. So now anything when we talk about the reason not known, it is basically referred to as hidden hearing loss. Hidden hearing loss, the most primary reason is quoted as cochlear synaptopathy, where the neuronal connections are not proper, and that is considered to be the site of origin for most of the hidden related problems. And it could be due to the stereociliar bundle, the noise damage. This is the first structure that the noise can induce changes, where the stereocilia can become entangled, it loses its shape, it can get collapsed. So all these things can be also a reason for the generation of tinnitus. And a group of hair cells which are non-functional, the outer hair cells and inner hair cells, and the rupture of basilar membrane. So these are all the probable reasons. So what is it leading to? This leads to a decrease in the neuronal output from the cochlea. So any of these things what is given there could rise to a neuronal reduction of neuronal output from the cochlea to the brain, and generation of compensation mechanism of the brain is the source of generation of tinnitus. Sometime back I said, if there is an output reduction from the inner hair cell, the dorsal cochlear nucleus tried to out cochlear synaptopathy. 2009, 2015, and even in 2016 they have an article which talks about how cochlear synaptopathy is caused and all that. Okay, so now to continue, the inner haircells and the cochlear NMDA receptors. So for noise-induced tinnitus, aberrant NMDA receptor activation and release of the auditory nerve excitation has been suggested as a cause of tinnitus generation, and increase in the glutamate. So what is it leading to? So this particular thing can lead to increase in the glutamate levels that is derived from the inner hair cells and activate the NMDA receptors that release in the excessive calcium. This excessive calcium released during the depolarization process that can lead to the synaptic damages. So more than required glutamate, more than required neurotransmitters when it gets released into the system, there is high chance of damage to the auditory structures. So this causes an overexcitation of NMDA receptors. Consequently, a calcium influx induced during the damage. This process may contribute to hearing loss via neural presbycusis and tinnitus via the aberrant excitation of auditory nerve. So these are some reasons which can cause for the generation of tinnitus. So something is called as the ribbon. These are the synapses that are there inside the hair cell. So this releases the glutamate into the synaptic cleft, and this ribbon synapses are generally affected when they are exposed to noise. So sometimes sir asked about that question about extended high frequency audiometry. So most of the time what happens is most of the individuals will have a threshold normal up to 8000 hertz, but may have losses at frequencies above that, which is not significant for our perception because as I told some time back, what is the most important frequency for us? 250 to 6000 hertz, because that covers the most of the natural sounds that are required for humans to communicate. But otherwise, we have a larger perception range, right? But even when there is a problem at a higher frequency range, above 8000 hertz also, there can be issues like this, like in terms of, that is otherwise called as the hidden hearing loss. Okay, treatment they have given, that is, sodium salicylate generally causes hearing loss. So what they found is that when this particular treatment was done, they found that the ribbon synapses are the ones which are getting affected. You can see in this image, this is in the control group, and this is in terms of the the treated group with sodium salicylate. So there is change in terms of how these things are coded. Like basically, you can see there is the position what it is there. The entire thing is getting shifted from the normal position to the other position. Fast damaged. So that is one other study which says about how the tinnitus relation is happening. So another thing is sometime back which I told about. It is in the bottom, which I send the information appropriately due to some damage in the synaptic cleft. So that is when